address the commonly tested recurring previous year topics. So we'll touch those topics, and also we will address some extra points that can be asked as potential MCQs. We'll not restrict ourselves to just the question that we are discussing. Now, all these questions are also already available on the Predictor series book. So if you are having the Predictor book, please go through and complete the entire medicine Q1 from that. And trust me, you can expect a sizable number of questions from that book itself. Okay, so let me start with the very first question. The question is, an MRI brain image is given below. You can see the image here. Okay, and they have told that it shows marked caudate nucleus atrophy. That's the hint. Caudate nucleus is atrophic with enlarged frontal horns of the lateral ventricle. The lateral ventricles are enlarged. That's what the question says. The patient has progressive coriform movement, means patient has a movement disorder. And what is the name of the movement disorder? Patient has chorea. And we know that chorea is an abnormal dance-like involuntary movements, where patients will have dance-like involuntary movements, and it is due to lesion in caudate nucleus. Now, first thing, you should tell me what are the conditions that cause chorea. From there, we can figure out which condition this particular question is talking about. So, what are the conditions that cause chorea? The most common cause for this involuntary movement called chorea is hyperglycemia. So, hyperglycemic injury to the caudate nucleus is the most common cause. So, uncontrolled diabetes. But apart from that, I want you to remember two more conditions. One of them you study in cardiology, the other one in neurology, or maybe in biochemistry. The one that you study in cardiology is a major criteria for diagnosis of acute rheumatic fever. Yes, what is it? Sydenham's chorea. So apart from that, so when we look at the causes for chorea, we should keep in mind that Sydenham's chorea that we talk about is due to antibody mediated injury to the caudate nucleus in rheumatic fever. Sydenham's chorea in rheumatic fever. It's a major criteria for diagnosis of rheumatic fever. Okay. And then the other one is an inherited disorder, that is Huntington's disease. Huntington's disease. Okay. So if we know these causes, then answering this question is pretty simple. There's nothing difficult there. So in Parkinson's disease, we do get involuntary movements, but that's not chorea. In Parkinson's disease, what do we get? In Parkinson's disease, we get pill rolling tremors, which are basically resting tremors. In Wilson disease also we get tremors. What kind of tremors we get in Wilson disease? Wilson disease tremors are postural tremors. The Parkinson's disease tremors are rest tremors. The Wilson disease tremors appear only when we try to ask the patient to elevate their shoulders and try to approximate the fingers at the eye level. Then the shoulder level movements start occurring. It is like the beating of the wings of a bird. So we call that as wing beating tremor. Wing beating tremor. So in Wilson disease we are getting wing beating tremor. In Parkinson's disease we are getting pill rolling tremor. Tardive dyskinesia is a side effect of various drugs. It is Huntington disease where we get to see chorea, and that's why often Huntington disease is also called as Huntington's chorea. So you can call it as Huntington's chorea or Huntington's disease. And it is an inherited disorder. It's a trinucleotide repeat extension disorder, or CAG repeat extension disorder. So there is excess number of CAG repeats. So it's a CAG repeat extension disorder. So our answer for this question should be option A, Huntington's disease. What are the additional MCQs we're expecting from this topic? What is the site of lesion in chorea? The site of lesion, C for C, caudate nucleus for chorea. Second, they will ask you what is the most common cause. It has been asked multiple times in the INI-CT. So again, it might be asked. The most common cause is hyperglycemia, right? Apart from that, you should be aware about Sydenham's chorea. Okay. What else they can ask you? They can also ask you other movement disorders and their sites of lesion, right? So please remember, If you're talking about chorea, these are all non-rhythmic movement disorders. Non-rhythmic movement disorders. Tremors come under rhythmic movement disorders. Or okay, let us just spend 5 minutes quickly noting down the movement disorders. So movement disorders are those conditions where either there is excess movements than required, or there is lack of movements, less movements. So on that basis, we classify the movement disorders into hypokinetic, where the movements are decreased, or hyperkinetic, where the movements are increased or involuntary. So for hypokinetic movement disorder, we have one example, that is bradykinesia, that we get in patients with Parkinson's disease. Bradykinesia of Parkinson's disease is a classical example for hypokinetic movement disorder. And when we are talking about hyperkinetic, we will further divide them into two groups. Rhythmic. Rhythmic means the same movement keeps repeating again and again like a rhythm. You know, if there is a song playing, singer is singing the song, but behind there is a rhythm going on. Someone is playing the tabla with the same beat appearing again and again repeatedly. It's the same rhythm that keeps recurring. So if the same movement keeps recurring, we will call it as hyperkinetic rhythmic movement disorder. So it can be rhythmic or non-rhythmic. Now remember, for rhythmic, we should be thinking about mainly two. What are those? The first one is tremor and the second one is dystonia. Tremors and dystonia are rhythmic movement disorders. And for non-rhythmic, you should think of three. The first one is chorea. Second one is athetosis. And the third one is balismus. These are your non-rhythmic movement disorders. The tremor we will further classify into rest tremor, where tremors occur when the affected limb is at rest. Second, we will also have action tremor or intention tremor, where the tremor appears on voluntary movement or action. And third, postural tremor, where the tremor appears only on certain posture, especially when the limb is held against gravity. So for rest tremor, we have an example, and that example is the Parkinson's disease. The pill rolling tremor of Parkinson's disease is a classical example for the rest tremor. On the other hand, if you ask me to give an example for an action tremor, where tremor appears on voluntary action, when the limb is moved, the tremor appears. At rest, it may not be there. The first thing that comes to my mind as an example here is the cerebellar disorders. So when cerebellum gets damaged, for whatever reason, even alcohol, when you're intoxicated, you start developing shaky hands, right? That's because of this action tremor. Postural tremor, we have so many examples. So one example for the postural tremor is your essential tremor, where the tremor appears when the limb is held against the gravity like this. Essential tremor is a postural tremor. A potential MCQ point, they are certainly going to ask one question on the movement disorder, and it could be now this time about essential tremor. So what kind of tremor is essential tremor? Essential tremor is a postural tremor. The tremor appears when the limb is held against gravity. Okay. The other example for essential tremor is the wing beating tremor. Wing beating tremor, which is seen in Wilson's disease. So wing beating tremor is seen in Wilson's disease. Okay. And then drug withdrawal tremor. This MCQ has appeared in the FMGE, like alcohol withdrawal tremor or a narcotic withdrawal tremor. What kind of tremor it is? They are also postural tremors. So at rest, tremor may not be obvious, but when the limb is held against the gravity, the tremor appears. And because this has already appeared as an MCQ, it remains an important point. Okay, so this is about the classification of movement disorders. What MCQs we are expecting? Where do you get rest tremor? Where do you get action tremor? And most importantly, which of the following tremor is postural tremor? With respect to non-rhythmic movement disorders, mostly they will ask you the site of lesion or identification of that non-rhythmic movement disorder from the symptoms or the description of the movement disorder. So when it comes to the non-rhythmic movement disorders, we discussed about 3, right? So we should know the movement disorder, its description and site of lesion. Movement disorder, its description and the site of lesion. So in case of the chorea, we already know that the site of lesion for chorea is caudate nucleus. And in this particular question, because they gave us the hint that caudate nucleus is atrophic, we know that it is talking about chorea. And thinking about an inherited cause, we're thinking about Huntington's disease. What is the description that they will provide for chorea? They will mention that the movement, abnormal movement that we are seeing are dance-like involuntary movements. In fact, the word chorea comes from choreography. It appears that someone has choreographed these movements. The next one is athetosis. The usual description of involuntary movements here is snake-like movements or writhing movements. Snake-like writhing movements. So the words that I'm mentioning here are the buzzwords. So if you see a question on movement disorder which is talking about dance-like involuntary movements, you know it is about chorea. If it is talking about snake-like or writhing movements, it is about athetosis. And it is due to lesions in globus pallidus or putamen. They can produce athetosis. The third one is balismus. So what is this balismus? Balismus is usually described as violent flinging movements. Which is due to lesion in the subthalamic nucleus. Lesion is in the subthalamic nucleus. Then we call it as balismus. Okay. How do I remember these sites and the disorders and site of the lesion? It's pretty simple. C for C. Chorea for caudate nucleus. Balismus, how will I remember? Well, remember the biggest hitter of the cricket ball is Tala. Unfortunately, he did not play this IPL, but we know that he is the biggest hitter of the ball. So whenever ball comes to the stadium, Tala also should be there in the stadium. That's how you can remember balismus is subthalamic nucleus lesion. Okay, clear? So the basics that we need to know for movement disorders we have covered. Now let's move to the next question. In this question, we have a 45-year-old man who presents with sharp central chest pain. Okay, already question is giving you clue. The pain here is described as sharp. Okay, central means yes, it is retrosternal. That worsens with inspiration. Another potential clue given here. And also on lying flat. So what do you think? Is it the typical pain of angina or is it a pain of something else? So guys, remember the chest pain due to MI or ischemia, myocardial ischemia, what you call as angina is yes, retrosternal or central, just like in this question is retrosternal or central, but that pain is usually diffuse and it's not sharp, it's not sharply localized, and it is rather squeezing in type. It is squeezing in type or a constricting type of pain. So patients often come and complain of tightness rather than feeling like someone is stabbing. They don't complain of a sharp pain and has no relationship with the respiration. Physical activities can worsen angina and rest and nitrates can relieve. Right. So exertion tend to worsen it, while rest and nitrates may relieve. I said may relieve. So the description of the pain here is not fitting into the angina. So I'm already thinking of something else. Where do I get a retrosternal chest pain which is sharp or penetrating and it is worse on inspiration and lying flat? It's typical of pericarditis. Another differential diagnosis is pleuritis. Okay. Now, when we look at the ECG, it shows concave ST elevation. The typical ST elevation of MI is generally convex. So that is again going against the diagnosis of MI. And it is affecting multiple leads. So when MI occurs, you will see ST elevation in only the leads representing the wall of the heart which is going through infarction, not multiple leads. So if I have lateral wall MI, only lateral leads will show ST elevation. You will not see ST elevation in more than lateral leads. Okay. What else I find here? There is PR segment depression, which is not at all expected in a patient with myocardial infarction. So these points go against MI and go in favor of diagnosis of acute pericarditis. So that's pretty simple. We are dealing with acute pericarditis in this question. So when you see this ECG, you will notice that the ST segment is elevated, but it is concavely elevated. It is concave. Okay. And let me pick up a good lead to show you the PR segment depression. You can see it here. The PR segment is depressed. PR segment is depressed. So concave ST elevation plus depressed PR segment. You are already thinking about acute pericarditis. Okay. So let's write down some important points on this question. So the typical ST elevation of STEMI or ST elevation MI. Number one, the ST elevation is restricted to leads of affected wall. For example, if I have inferior wall MI, then the inferior wall is represented on the ECG by leads 2, 3 AVF. So then I will only see ST elevation in lead 2, 3 AVF. I will not see it in other leads. If I have anterior wall MI, anterior wall is represented by lead V3, V4. So I will have ST elevation in V3, V4. I will not have ST elevation in other leads, right? But in case of acute pericarditis, in acute pericarditis, the ST elevation is not confined to the vascular territories. ST elevation is not going to be confined to vascular territories. ST elevation in multiple leads, not confined to vascular territories. Okay, what else we can expect? In a standard 12 lead ECG, at least some leads have reciprocal leads, like inferior and lateral act as reciprocal to each other. So if I have inferior wall MI, then lateral wall is supposed to show reciprocal ST depression. And if I have the lateral wall MI, inferior wall is supposed to show reciprocal ST depression. But that rule of reciprocality is not usually seen in acute pericarditis. Reciprocal ST depression may be present. Not maybe, should be present if the leads have reciprocal leads present for them. While you don't get that in acute pericarditis. You may not have reciprocal ST depression. Third, the other segments, there is no PR segment depression, while you get PR segment depression, which is kind of hallmark of acute pericarditis. PR segment depression is a hallmark of acute pericarditis. Okay. Fourth, the ST elevation that we get in typical STEMI, often, I'm saying often, not always, the ST elevation may be convex upwards. Convex upwards. While the acute pericarditis, the ST elevation is generally convex, generally concave upwards. So here, if this is P, then Q, R, ST segment might appear like this. So this is a convex ST elevation. We will have a convex ST elevation, and often this convex ST elevation was called as tombstone sign because this ST elevation looks like the tombstones that we see in the graveyard. Okay. While the ST elevation that you are getting here in acute pericarditis is going to be like, you'll have first of all the PR segment which is depressed, and then ST segment which is concavely elevated. So this is a typical finding, right? You will have a depressed PR segment and an elevated ST segment, but ST segment elevation is generally convex, not concave, not convex. So these findings generally help you to differentiate between MI and acute pericarditis. Clear? So in this case, our diagnosis will be acute pericarditis because the question is clearly talking about, and image is also showing that there is concave ST elevation, multiple leads, not restricted to one vascular territory, and also there is PR segment depression. Plus the pain is also more in favor of acute pericarditis. So the pain of acute pericarditis, just few more extra points. The chest pain in acute pericarditis. The MI pain was retrosternal. This is also retrosternal, means central to the chest. But this pain is more sharp or penetrating in nature. Sharp or penetrating in nature, and it is worse on inspiration. Deeper breaths hurt more. Worse on inspiration and on lying down supine. In the opposite of it, expiration, the pain gets better, and sitting up and leaning forwards, the pain gets better. Okay. So if any question that is talking about pain that is worse on inspiration and on lying down, and you're seeing some ST elevation which is concave with PR depression in multiple leads, you know you're talking about acute pericarditis. Remember, if they're asking you what is the most common cause for acute pericarditis, idiopathic is the most common cause, followed by viral. Okay. And when it comes to the treatment of acute pericarditis, we generally tend to treat them with, because most common is idiopathic, second most common is viral, so we don't have anything specific to treat. So we try to treat them with the NSAIDs like aspirin or diclofenac plus colchicine. And please remember another potential MCQ that they might ask, adding colchicine decreases recurrence risk. So we're adding colchicine to reduce the risk of recurrence. Because see, idiopathic is the most common cause. And if it is idiopathic, I don't know what is causing it. So I can't eliminate the underlying cause. So if I'm not able to eliminate the underlying cause, it can come back again. So adding colchicine to the initial management reduces the risk of recurrence. Okay. Now let's go to the next question. A 74-year-old male presents with complaints of shortness of breath and palpitations. Shortness of breath and palpitations. Patient appeared fatigued. On examination, a murmur similar to image given below was heard. He has a history of rheumatic fever. Okay, so I get one potential clue here. X-ray revealed enlargement of left atrium. What is the most likely diagnosis? So first thing we can conclude that if left atrium is enlarged, the pathology is affecting the left side of the heart. So if I am having a valvular heart disease, it should be MS, MR, AS or AR because it's a left-sided pathology because left atrium is enlarged. If right atrium was enlarged instead of left, I would have thought about the TS, TR, PS, PR. Okay. And when I look at the options, all the options are about left. So there's no confusion about right versus left here. The examiner has kept it simple. Now what other clues I'm getting in the question? It is talking about rheumatic fever. Patient has history of rheumatic fever. So if someone is having history of rheumatic fever, not going through right now, but had, then chances are that patient might have developed what you call as rheumatic heart disease. And if he has developed rheumatic heart disease, what's the most common valvular lesion? The most common valvular lesion in rheumatic heart disease is going to be mitral stenosis. Most commonly affected valve in rheumatic heart disease is mitral valve, and the lesion is mitral stenosis. So MS is the most common lesion that we are expecting. Okay, so this is from the context, but I still have to look at the image and then come out with a conclusion. So can anybody look at the image and tell me what is this murmur? Is it a systolic murmur or diastolic murmur? See, there is no marking of which is S1 and which is S2. So what do you think? What do you think it is? I'm not getting any of your texts. Is it a systolic murmur or diastolic murmur? Okay, well, remember guys, the duration of systole is generally shorter. The duration of diastole is generally longer. So systole runs for a shorter period of time in comparison to diastole. So if that is the case, then this part is most likely diastole and this part is most likely systole. And we know that systole occurs between S1 and S2. So let me label this as S1 and this as S2. In that case, right, this is again going to be S1. So now, based on this knowledge that generally diastole runs for a longer period than systole, I can label this as diastole and this as systole. Most of the MCQs asked so far have clear marking of S1 and S2, but in this there is no marking, so I'm presuming that the second part is diastole because it is running longer. And now when I look at it, this is my S2. Okay, so after S2 there is nothing going on, and then somewhere here I can see oscillations or vibrations on the phonocardiogram. That means the murmur started here. After that the murmur became louder in intensity. So what murmur is this? The murmur did not start in the early part of diastole, so this is not early diastolic murmur. Murmur is not running throughout the diastole, so I can't call it as diastolic murmur. Murmur is not running in the last part of the diastole, so I can't call it as late diastolic murmur. Somewhere in the middle it is beginning, so we can call it as a mid diastolic murmur, and its intensity is increasing towards the end of diastole or before the beginning of next systole. So can I label this as a mid diastolic murmur with pre-systolic accentuation? Yes, basically this is a mid diastolic murmur with pre-systolic accentuation. So where do we get mid diastolic murmur with pre-systolic accentuation? There are only two valvular heart diseases where we get mid diastolic murmur with pre-systolic accentuation. So let us put a small table of the valvular heart diseases and their murmurs. If you have no understanding of cardiac physiology and the valvular heart diseases, it's fair. I just want you to by heart this table. With this table, I'll give you some hacks so that you can answer most questions from valvular heart disease. And we will apply the same knowledge to deal with this question as well. So remember, if you talk about the valvular heart disease, the murmur that we get, if you're talking about the mitral stenosis and tricuspid stenosis, both cases you get the same murmur, which is going to be like, it's going to be a mid diastolic murmur which becomes louder just before the next systole begins. So we call it as mid diastolic murmur with pre-systolic accentuation. So this will be heard between S2 and S1. So first part of the diastole is generally isovolumetric relaxation. That is where you don't hear the murmur. After isovolumetric relaxation, generally valve opens and opening of stipped valves can make a sound, and that sound we will call it as opening snap. So in patients with MS and TS, you can hear the sound of opening of the valves, and that is called as opening snap. And after that, when the blood starts moving during the passive filling from atria to ventricle, it is passing through narrow mitral valve or narrow tricuspid valve, so it starts making the noise. This noise is what we are calling as mid-diastolic murmur. And after the passive filling, when we get into active filling where atria forcefully contracts to push the blood into the ventricle, the turbulence increases across the valve and the murmur intensity increases. So we call this as a mid-diastolic murmur, and this increase in intensity is what we call as pre-systolic accentuation. Pre-systolic accentuation. Accentuation means increase in intensity. Accentuation means increase in intensity. So in MS and TS, you will get the same murmur. What changes is where you hear it. In MS, the murmur will be heard in mitral area, and in TS, the murmur will be heard in tricuspid area. Symptoms also change. In MS, it is left-sided symptoms, means enlarged left atrium, congestion of the lungs, so patient will have shortness of breath, orthopnea, PND. In TS, right-sided symptoms, means raised JVP, hepatomegaly, ascites, and enlarged right atrium. Okay. Then, if you talk about mitral regurgitation and tricuspid regurgitation, both of them produce. So here you will also have an opening snap, as I've already told you. Opening snap followed by a mid-diastolic murmur with presystolic accentuation. In case of MR and TR, the murmur will be pan-systolic. It will be pan-systolic murmur. That means the murmur runs throughout the systole. From S1 to S2 is our systole. So this murmur will be running throughout the systole. What changes between MR and TR? Again, the area and symptoms. If I have MR, it's a left-sided disease, so you will have congestion of the lungs and you will have orthopnea, PND, shortness of breath. If you have TR, you will have congestion of the right side of the system, that is raised JVP, hepatomegaly, ascites, PND. Okay. Then AS and PS will have same murmur. What is that? You will have the opening of the valve making a sound, which we call as ejection click, and that will be followed by a crescendo, decrescendo, ejection systolic murmur. So how does this look like? So we're talking about systole. So whatever that is happening, it is happening between S1 and S2. So after S1, generally we get into isovolumetric contraction. Ventricle is contracting, but aortic valve or pulmonic valve are not open yet. So blood is not flowing through them at this point of time. So there is no turbulence, no murmur. After isovolumetric contraction is where the opening of the aortic and pulmonic valves occur, and sometimes if they are stenos, they can make a noise while opening. We call it as ejection click. After the click, the ejection starts. Initially rapid ejection and then slow ejection. So during this period of ejection, blood is passing through narrow aortic or pulmonic valve, so it makes the turbulence and creates the murmur. But because the flow velocity goes on increasing and goes on decreasing, the murmur intensity also goes on. Murmur intensity also goes on increasing and then eventually goes on decreasing. So we call this as crescendo, decrescendo murmur. The intensity is going up and coming down, a diamond shaped murmur. Okay. Now what are we left with? We are left with aortic regurgitation and pulmonic regurgitation. So both of them produce the same murmur, which is going to be an early diastolic murmur. So murmur of MS and TS was a mid diastolic murmur. The murmur of the MR and TR are pansystolic, while the murmur of AS and PS is ejection systolic. Now AR and PR produce decrescendo early diastolic murmur. Decrescendo early diastolic murmur. Decrescendo early diastolic murmur. Okay. So how is it going to look like? Being diastolic, it will be between S2 and S1. So first part of the diastole is isovolumetric relaxation, and that is where you hear this murmur with the intensity of the murmur crashing down, and you don't continue to hear that generally beyond isovolumetric relaxation phase. So this is how it looks like, a decrescendo early diastolic murmur. So I want you to by heart this table so that questions on this can be easily answered. Now, how do I interpret this knowledge? Just give me 1 second to answer the questions. Well, whenever you have a valvular heart disease question, murmur table I want you to by heart, and then I want you to see whether the symptoms are right-sided heart symptoms or left-sided heart symptoms. So valvular heart disease, 3 information to look at. Number 1, right versus left symptoms. So what are right symptoms? The right symptoms are raised JVP, ascites, hepatomegaly, and pedal edema. So if the question is talking about these symptoms, then patient is having a right-sided valvular heart disease. And if the question is talking about dyspnea or shortness of breath, orthopnea, that is shortness of breath in supine position, or PND, paroxysmal nocturnal dyspnea, it is pointing towards left side of the heart. So this generally takes you to the diagnosis. Or second, you should also look at the area of murmur, which part of the chest the murmur is best heard. For example, if it is right second intercostal space, then you know it is coming from aortic valve. So if the question is talking about a murmur best heard in the right second intercostal space, already examiner is telling you that either it can be AS or AR. So even if you just take a chance, like you don't know anything beyond this, you are not by heart at the murmur table, you don't know right versus left symptom, all you know is only the areas, still you have a very high chance or more than 50% chance that you will get it right, because you are left with only 2, AS or AR. You choose AS, 50% chance that you may be right, and if only AS is the option, AR is not there, you are already sorted, right? Then similarly, the left second intercostal space is the pulmonic area. So if the murmur is best heard in the left second intercostal space, that means it is coming from the pulmonic valve. Then if it is left lower sternal border, that is your tricuspid area. So if the question mentions that there is a murmur best heard in left lower sternal border, that means it is coming from tricuspid valve. So you have only 2 possible diagnoses, TR or a TS. The last one is apex or apical impulse, the point of maximal impulse that we can feel on the chest, and that's your mitral area. So if the question mentions that the murmur is best heard at the apex, means it is coming from mitral valve. So it could be MS or MR. So if you have these 3 levels of information, which murmur it is, from which area it is coming, and what are the symptoms, and if you apply your understanding of area, nature of murmur, and the symptoms, even if you know 2 of them, even if you get 2 of them right, you will always reach the diagnosis. For example, let's look at this question itself. Okay, now in this question, the symptoms that they're talking about is shortness of breath, which is primarily a left heart symptom. They're also mentioning that left atrium is enlarged. So I've concluded that this is left heart disease. So this is less likely to be PSPR, TSTR. Anyway, those options are not there. Second, we get to see the murmur. What is a murmur here? It is a mid-diastolic murmur. So if I have an idea about this table, that mid-diastolic murmur is encountered in MS and TS, I'm sorted. In the option, TS is not there, And from the symptoms also, even if TS was an option, from the symptoms, TS is ruled out, symptom is pointing towards left heart disease. So then I will directly conclude it as mitral stenosis. Why is this not aortic stenosis? Because aortic stenosis produces a systolic murmur. Why is not aortic regurgitation? Aortic regurgitation produces early diastolic decrescendo murmur. Why is this not MR? Mitral regurgitation produces again a systolic, which is pansystolic murmur. So by heart this table, be aware of right versus left symptoms and areas of auscultation. Most of your clinically oriented valvular heart disease questions are kind of sorted. We probably have some more questions on the similar lines. We will apply that there also, so that by the time we finish the class, you will have some idea how to deal with valvular heart disease questions. Okay. Now, next question. A 45-year-old female presents to the emergency room with severe headache, palpitations, and sweating. Patient reports these symptoms began suddenly and have occurred frequently. Means this is not a first episode. It is an episode of similar symptoms over past few weeks. What are the symptoms? Headache is there. Along with the headache, there is palpitation and sweating. And we know that palpitations and sweating coming together, do we experience it? Yes, we do experience when we are scared. Right? Why do we have like the feeling of palpitations and sweating when we are scared? It is because of the activation of sympathetic nervous system. When we are scared, we sweat, we palpitate, we can feel our heart racing. It's because of the activation of sympathetic nervous system. There is release of adrenaline, noradrenaline, and dopamine, which are catecholamines, which stimulate the heart to contract with more force and beat at higher rate. That high rate of heart and its forceful contraction can make us feel the heart contracting, and that's why we feel that as palpitation, right? So same thing, but patient is going through again and again. So what it can be? In migraine, we are not expecting to see palpitations. In migraine, we are not expected to see sweating. What we are expecting in migraine, patients with migraine may have aura, some abnormal sensory perception like flashing of lights, floaters, right? Or some transient vision loss. So like we may be having aura. Apart from that, migraine patients may have photophobia, may have phonophobia, intolerance to bright light and loud noises. They can have nausea or vomiting. And another clue examiners might give is physical activities worsen migraine headache. But these clues are not there. So it is unlikely to be migraine. And to call it as migraine, I need to know that it is unilateral or bilateral and how long an episode of attack of headache was lasting. And I still can't explain palpitations and sweating from the diagnosis of migraine. Okay. Hypertensive crisis can explain headache. But to explain palpitation and sweating, I still need to think about the sympathetic nervous system. So I'm left with only one choice which can explain occurrence of headache because of high BP and also palpitations. And what is that? Pheochromocytoma. So what is pheochromocytoma? It's an adrenal medullary tumor. Adrenal medulla tumor. And what this tumor does, this tumor secretes, because it is originating in the medulla, it secretes, and there are two pulsatile. There will be pulsatile, means there's no continuous secretion. Pulsatile secretion of catecholamines. What are catecholamines? Adrenaline, noradrenaline, and dopamine. So pheochromocytoma is a condition where you will have adrenal medullary tumor which will have pulsatile catecholamine secretion. And because of this pulsatile release of catecholamines means we're talking about adrenaline, noradrenaline, and dopamine. These, when they come into the blood, they will cause vasoconstriction, they will stimulate heart. By stimulating heart, they will increase heart rate, and this increased heart rate makes the patient feel the cardiac contraction, so it can lead to palpitations. Vasoconstriction will lead to hypertension. This hypertension is often called as episodic hypertension because the catecholamine release is episodic, pulsatile, not continuous. So only when catecholamine gets released, BP shoots up. If I take BP reading when the catecholamine surge is not happening, BP may be normal. Okay, so any question that talks about episodic hypertension and palpitation is most likely talking about Pheochromocytoma, right? So that's going to be our answer. Okay, now let's go to the next question. Harun Suleiman, can you tell me what is the point that you are not able to get? I will try to reiterate again. Okay, so the next question is, an elderly patient brought to the clinic by grandson with a complaint of chronic cough and sputum production. He has a 30-year smoking history. Chest X-ray of the patient reveals similar following findings. Which of the following is the most likely diagnosis? So what are the key points here? There is chronic cough with sputum production. He is a smoker with 30 years smoking history. We are already thinking about the possibility of COPD. We have to just see. And another possibility is we are thinking about lung cancer. We have to just see whether X-ray agrees with that or not. So when you see X-ray, what are the findings you are noticing? In the X-ray, one thing that is very striking and clearly evident to me is the diaphragm, which is flattened. Normally, diaphragm is like a dome. There is a right dome and a left dome. Right dome is slightly higher than the left because of the presence of liver here. But that dome-like appearance is no longer there. The diaphragm is flattened. So in this X-ray, we are seeing flattened diaphragm. Flattened diaphragm. Number two, heart appears more like heart appears like it is squeezed from both the sides. A normal heart is like this, but here it appears like squeezed from both the sides, what you call as tubular heart. So what do you think these findings are pointing towards? Are they pointing towards lung cancer or are they pointing towards COPD? Yes, basically we have hyperinflated lungs here. The lungs are expanded in size because of air trapping. Why there is air trapping? Because of emphysema. What is emphysema? Irreversible dilatation of alveoli or acini. So when alveoli get irreversibly dilated, they can get more air into it. But how do we send the air out from the alveoli during expiration? Because of the recoil. These are irreversibly dilated. So we will not be able to send the air out. So air gets trapped in the lungs. Lungs start expanding in the size. As they expand, they will push the mediastinum from both the sides. So mediastinum become narrow. That's why you get tubular heart. And the expanding lungs also push the diaphragm down. That's why the dome becomes flattened. So these are typical findings of emphysema. So we will conclude the diagnosis as COPD. And in fact, in this question, we find evidence of two components of COPD. One, X-ray is suggestive of emphysema. On the other hand, the symptoms are also suggestive of chronic bronchitis because there is chronic cough with sputum, right? So just 2 minutes, we will take a look at the subcomponents of COPD. So if you talk about COPD, there are two subcomponents. One of them is emphysema. The other one is chronic bronchitis. Chronic bronchitis. So how do we define emphysema? Emphysema is defined as irreversible dilatation of acini, or if you want to remember it as alveoli, you can remember it as alveoli. While chronic bronchitis is a clinically defined entity. We have defined chronic bronchitis as cough with sputum, not dry cough, cough with sputum for more than or equal to 3 months per year. Means each year patient should have cough for at least 3 months, which is with sputum for 2 sequential years. So for 2 sequential years, if patient has cough with sputum, each year at least 3 months there was cough, then we will call it as chronic bronchitis. Patients with chronic bronchitis are also called as blue bloaters. They are called as blue because of the chronic bronchitis. They tend to develop cyanosis. Along with cough, they have cyanosis, and there is increased risk of right heart failure. Increased risk of right heart failure. And when right heart fails because of COPD, what do we call it as? A lung disease resulted in heart failure. Lung disease resulted in heart failure. We will call it as COR, means cardiac problem, but because of the pulmonary problem. So COR pulmonale. Okay. Emphysema patients don't have much of cough. They don't have sputum production. What is their problem? The acini are irreversibly dilated. Air can come in, but we can't send the air out. So because of that, there will be hyperinflation of the lungs. So they don't have cyanosis. So we call them as pink puffers. They are called as pink puffers because there is no cyanosis here. There will be hyperinflation of lungs, and this hyperinflation of lungs results in some peculiar findings. So one of the peculiar finding is going to be what we call as barrel-shaped chest. Barrel-shaped chest. Another finding we can notice is these patients find it very difficult to exhale the air. So they try to make it easy to exhale the air, and they do some physical adaptations. So one of those adaptations is pursed lip breathing. They don't breathe like normal. They breathe. This pursing the lip builds the pressure inside the airway, and that high pressure helps you to bring the carbon dioxide trapped in those dilated acini to come it out, to bring it out. So we call that as pursed lip breathing. And another maneuver that helps them easily exhale the air that is trapped in the dilated acini is to bend and breathe. So when they bend, diaphragm gets pushed up, lung gets squeezed. So the squeezing of the lung pushes the air out. But of course, when I bend, I can't maintain posture. I have a tendency to fall forward. So for support, I keep my upper limb or arms on the thighs. We call this as tripod position. Tripod position. So these are some additional points we should know about chronic bronchitis and emphysema. And on this X-ray, hyperinflated lungs show up as flattened diaphragm, wide rib spaces, and tubular heart. Babu Sharma, the notes will be available on the PW Telegram after the class. Okay, so this was a pretty straightforward radiology question rather than medicine. Okay, this is again a very straightforward question. I'm sure all of you will answer this. A 23-year-old female was brought to the clinic with joint pain, swelling, and fatigue, and a rash on her face similar to the image given below. ANA is positive. What is the most likely diagnosis? So when you look closely, you will see redness here and redness here. There's not much of redness involving the nasolabial fold. So what's the diagnosis? It's a pretty simple malar rash, and we know the diagnosis is systemic lupus erythematosus, SLE. Now what additional points I need to know about SLE? Yes, in the SLE, first thing is recognizing that this question is about SLE. Most of the SLE questions nowadays are not ending at this level. What is the diagnosis? They are like, okay, I'll give you the information. Mentally, you make the diagnosis of SLE, and then I will ask you something about SLE. You should be able to answer that. Nowhere in the question I will directly tell you that this is about SLE. You have to make a mental diagnosis based on the story, and most stories are about malar rash, photosensitivity. But what they ask beyond that is which of the following is the most sensitive antibody, which of the following is most specific antibody, which of the following, presence of which of the following antibody in this patient suggests drug-induced SLE, or presence of which of the following antibody in this patient indicates higher risk of neonatal lupus. So we'll take a look at the antibodies in SLE. So when we talk about antibodies in SLE, remember the most common antibody, or thus also the most sensitive antibody, is going to be ANA. ANA is the most common and most sensitive, but not specific. Even normal individuals who do not have any autoimmune disorder can also be ANA positive. At low titers, they can have ANA. So it is not specific. If they're asking you what is the most specific antibody, the most specific antibody is going to be anti-Smith antibody. Anti-Smith antibody. But then there's one antibody which is clinically the most important antibody, which is second most sensitive. After ANA in terms of sensitivity, it is second most sensitive and also second most specific. So after anti-Smith, it is the second most specific. Which one is that? It is your anti-double-stranded DNA antibodies, anti-dsDNA antibodies. Extra point about anti-dsDNA antibodies is that anti-dsDNA antibodies correlate, the titers correlate with disease activity. Disease activity. So if I've started treating SLE and if the treatment is going well, the anti-dsDNA titers come down. If treatment is not going well or disease is getting worsened, the anti-dsDNA titers increase. I can't say the same about ANA. ANA titers do not correlate, right? Remember, ANA titers do not correlate with disease activity. That's why we use ANA for initial diagnosis. But after that, we don't repeatedly keep checking the ANA titers. It makes no sense whether ANA titer is increasing or decreasing. It has no correlation with disease activity. But anti-dsDNA has. This is again a potential MCQ point that might be tested. Okay. And then the anti-dsDNA titers also correlate with risk of kidney involvement. Correlate with risk of kidney involvement. We call that as lupus nephritis. So it correlates with the risk of lupus nephritis. Okay. Then they will also ask you the antibody suggestive of drug-induced lupus. Drug-induced lupus. The antibody suggestive of drug-induced lupus is anti-histone antibodies. Anti-histone antibodies. Another MCQ they might ask, and in the last INI-CT just a few days back it was asked, which antibody correlates with the risk of neonatal lupus? Antibody correlating with risk of neonatal lupus. So what is neonatal lupus? If the pregnant mother has SLE and she has this antibody, then these antibodies can be transplacentally transferred to the fetus, and fetus can develop SLE, not because it has autoimmunity, but because it has passively received the antibodies from the mother. So presence of which antibody actually correlates with the risk of neonatal lupus? And that's going to be your anti-Rho antibodies, also called as anti-SSA antibodies. Anti-Rho or anti-SSA antibodies. So these are some potential MCQ points on the antibodies. What else they can ask on SLE? They can also ask you about the organ manifestation. Most common manifestations. And when we're talking about most common manifestation, it's like about individual organs. The most common musculoskeletal manifestation. Most common constitutional symptom. The most common cardiovascular manifestation. The most common central nervous system manifestations. The most common respiratory system manifestation, right? The most common musculoskeletal manifestation is polyarthritis. So you get polyarthritis also in rheumatoid arthritis, right? So how is the arthritis of SLE different? That is going to be another MCQ template. So in rheumatoid arthritis, the polyarthritis is bilaterally symmetrical, and so is here in SLE also. It is bilaterally symmetrical. Okay, so no difference between rheumatoid and this. It affects upper limb more than the lower limb. In rheumatoid arthritis also same. It affects small joints more than large joints. So rheumatoid arthritis also same. Rheumatoid arthritis affects the small joints of your hand most commonly, right? Sparing distal interphalangeal joint. So it is similar here also. Then what is the difference? This is an inflammatory arthritis, not degenerative. So if it is inflammatory arthritis, this will be associated with early morning stiffness lasting for more than 1 hour. Same as rheumatoid arthritis. So in rheumatoid arthritis also you have early morning stiffness lasting for more than 1 hour. So then what is the difference? The difference is in rheumatoid arthritis there is joint erosions. It is an erosive polyarthritis which leads to joint deformities. In SLE it is not an erosive polyarthritis. So true joint deformities don't occur here. It's a non-deforming arthritis. Okay. So that's a very important point. It is a non-erosive arthritis. That means there will be no true deformities. While in SLE you get Z deformity, swan neck deformity. So you don't have those deformities here in SLE. Okay. The most common constitutional symptom is going to be fever. Most common cardiovascular manifestation is going to be pericarditis. Pericarditis. And the most common respiratory manifestation is pleuritis. Pleuritis. The most common CNS manifestation is going to be cognitive dysfunction. Means a slight reduction in the higher mental functions capabilities of the brain, like kind of you can say similar to dementia. There is loss of cognitive functions. The manifestation of that is in the form of what you call as brain fog. Brain fog. So where patients' thought process is slowed down. Okay, so these are most common manifestations. Okay, now let's go to the next question. In this question, we have a 43-year-old construction worker. Presents with 2-year history of progressive shortness of breath and cough with sputum production. He has no history of smoking and works as a mason. Clinical examination reveals fine crackles on lung auscultation and chest X-ray was similar to the image shown here. So first of all, the question is talking about construction worker and he is not a smoker and he is having chronic cough. So should I be thinking about the COPD here? COPD is less likely because he is not a smoker. Then what other conditions I can think of? If he is a construction worker, it can be a pointer towards what you call as occupational lung disorders. And a construction worker is prone for what all occupational lung disorders? They will be mainly prone for 2 occupational lung disorders. So any question that is talking about construction worker, think about 2. Number 1, silicosis. Because there is a lot of use of sand blasting, right? All of that. So silica particles can be generated or aerosolized and which patient may be inhaling. Second, nowadays banned, we don't use, but once upon a time there was rampant use of asbestos in plastering work and all. And nowadays also some builders illegally may be using it. So asbestosis is another possibility. So I should be thinking about these 2 possibilities as occupational lung disorders. Okay. In India, TB will always remain a differential diagnosis for anyone presenting with cough of more than 2 weeks. So TB cannot be just ruled out like that. So in this case, I am thinking about silicosis, asbestosis and tuberculosis. 3 possibilities. I'm not thinking about COPD because he is not a smoker and there's nothing mentioned about alpha-1 antitrypsin deficiency or any exposure to other forms of smoke. Okay. So now you look at the X-ray and tell me what do you think. We have come down to the differential diagnosis of silicosis, asbestosis and the tuberculosis. He is working in construction industry, not coal industry, so I'm not thinking about coal workers pneumoconiosis for sure. Inducennial, we are expecting around 4 to 6 questions from cardio, but if you also figure out, if you also consider the questions coming from pharma side with a little touch of medicine, the number goes to 10 plus. Because heart failure, antiarrhythmics, antihypertensives, between these three, at least 2 questions are expected from pharmacology as well. So what are the findings you are noticing here on this X-ray? Well, when you see this X-ray, first thing you notice is that there are some coin-like opacities spread across the lung field, right? Agreeing? Okay. Now, let's look at it. The bronchitis does not show up with any changes on the X-ray. There may be some increased bronchovascular markings, but not specific. So bronchitis cannot be diagnosed on the X-ray. It's a clinical diagnosis supported by the presence of obstruction on the PFT. Silicosis can be diagnosed on the X-ray. Pneumonia can be diagnosed on the X-ray. Pneumonia will be of two patterns. One of them is called lobar pneumonia. The other one is called as bronchopneumonia. In bronchopneumonia, there will be patchy opacities spread across the lung, somewhat similar to what you're getting on the X-ray, not exactly like that, but somewhat similar. In lobar pneumonia, one lobe will be affected, and from radiology, you know that lobar pneumonia will have the definitive sign of consolidation or solidification of the lung due to pneumonia on the X-ray is going to be presence of what you call as air bronchogram. So the opacity that we see, within that opacity, you will be able to see the bronchi running, which are air filled. Like if I have, let us say this is one opacity. Within this, you will be able to see a dark bronchi. So if you are seeing that, it is called air bronchogram, because when pneumonia occurs, the acini or alveoli get infected, they become solidified, but not the bronchi. So bronchi are patent, so air will be there in that. So it will not be opacified. There will be surrounding opacity, but bronchi will be air filled, so they will be dark. So we call that as air bronchogram. And I don't find that anywhere on the X-ray. And another important reason why I am not thinking of pneumonia in this case is no one survives for 2 years with pneumonia. At the end of 4 to 6 weeks, either pneumonia stays or patient. Means if pneumonia is staying there, then patient can't stay. Most of the patients who are not coming out of pneumonia would be dead by 4 to 6 weeks time. Or if patient is staying, that means pneumonia can't stay. With antibiotics or patient's own immune response, the pneumonia is resolved. You will not have pneumonia continuing for years together. So that's why this can't be the answer here. Okay. Then tuberculosis, we already know that tuberculosis predominantly affects the upper lobe. There can be upper lobe cavitary lesions. In the tuberculosis, you can have hilar lymphadenopathy. Tuberculosis often has pleural effusions. These findings are not seen here. There is no hilar lymphadenopathy, there is no upper lobe cavitation, so it is unlikely to be tuberculosis. So I'm left with only silicosis, and what you are seeing here, they are basically showing what is called as eggshell calcification. Eggshell calcification, making silicosis as the likely diagnosis. Occupation also fits into it, and duration also fits into it. X-ray image also fits into it. So the question is talking about silicosis, not tuberculosis, not pneumonia, not bronchitis. If I had, let us say, asbestosis, which is a possible differential diagnosis, in that case, X-ray is not in favor of asbestosis. In the asbestosis, yeah, you can have mesothelioma, and the pleural involvement leads to some findings or opacities which are resembling the clover leaf. So you will have something called as holy leaf sign or clover leaf sign on the X-ray. Those are not seen here. Okay. Now let's go to the next question. I'm expecting a question on this particular topic, either from medicine, path, or biochemistry. The question is about a 49-year-old male presented with severe pain, swelling, and redness of his right elbow joint. So is it polyarthritis or monoarthritis or oligoarthritis? If there is involvement of 5 or more than 5 joints, it's polyarthritis. And 2, 3, or 4 joints, it is oligoarthritis. And only one, it is monoarthritis. Here it is only about elbow joint. So that means patient has got monoarthritis. And one of the important differential diagnosis for recurrent or episodic monoarthritis is gout. It is gout. Right. So tell me, where do we get monoarthritis? Gout is one cause. Okay. Then the other condition is septic arthritis, where there is infection of the joint. Septic arthritis. Your rheumatoid arthritis is polyarthritis. All your enteropathic arthritis is polyarthritis. Then spondyloarthropathies, including reiters, that is oligo to polyarthritis. SLA arthritis is polyarthritis. So if you're thinking about mono, you should be thinking about gout or septic arthritis. Now what else I mentioned? There is reports of similar episodes in the past, so which is already going in favor of gout. Septic arthritis is unlikely to be recurrent. And then laboratory investigations of the patient show that he has hyperuricemia. So they are telling me that this is a case of gout. So they are already telling me that we are thinking about gout. They are asking what is the most appropriate initial treatment. So should I start with steroids, antibiotics, colchicine or probenecid? Probenecid is a uricosuric agent. It increases the uric acid excretion. It increases uric acid excretion. So what should I choose here? Should I start with steroids, colchicine, antibiotics? Of course, this is not about septic arthritis, so I'm not thinking about antibiotics. Okay. Steroids are also not considered as a initial choice for management of gout. So whenever we diagnose gout, so if you have a suspected gout, when do I suspect gout? If there is monoarthritis, single joint arthritis, most often involving the great toe. Great toe is the most common site. Okay. And there is severe pain. It is not a mild pain. You can suspect the possibility of gout. After that, the gold standard, once you have suspicion, the gold standard for diagnosis. What is the gold standard for diagnosis? It is the synovial fluid analysis. Synovial fluid analysis. And what do I get on the synovial fluid analysis? The synovial fluid analysis will be looking at we will be looking for the needle shaped negatively birefringent monosodium urate monohydrate crystals. That's the gold standard for diagnosis. And once the diagnosis is done, we suspect it, we establish the diagnosis. Once the diagnosis is done, when it comes to the management, first step in the management is to reduce the ongoing inflammation. First step is not to reduce the uric acid levels. It is to reduce the inflammation. And how do you reduce the inflammation? You can reduce the inflammation by giving anti-inflammatory agents, potent NSAIDs plus colchicine. Colchicine is also an anti-inflammatory agent. After that, you progress to the second step where you try to reduce the uric acid level. That is uric acid lowering. So for that, what drugs I can use? I can use drugs like allopurinol. Yeah, indomethacin is a good NSAID, or ibuprofen can be used, naproxen can be used. Allopurinol or febuxostat, which are basically xanthine oxidase inhibitors, or you can use probenecid. And remember, this probenecid is a uricosuric agent. It increases the uric acid excretion by the kidney. Uricosuric agent. It increases the excretion of uric acid. What is the issue? Audibility is less, or you feel there is reverberation. Okay, if there is a reverberation, let me know. I'll tell the technical team to put some settings to reduce the reverberation. Okay, so this is how we are going to manage the case of gout. So in that case, this question is pretty straightforward. First step is going to be using colchicine along with NSAIDs to reduce the inflammation. After that, maybe I can consider probenecid. Otherwise, the preferred agent nowadays is allopurinol. But in patients with renal dysfunction, we choose febuxostat. Okay, just give me 1 second. I'll try to get the settings cleared. Just give me 1 second, guys. Okay, I hope now it is better. If still not better, let me know. Okay, I have asked the noise gate to be installed, so I hope it is better. If it is not better, let me know. Okay, now let's go to the next question. So in this question, again it's a pretty straightforward question. A 45-year-old male presented to the clinic with pain in the chest, difficulty swallowing, and regurgitation of food content. He has history of GERD. His symptoms are not resolved after consuming antacids. Okay, I'll just take a minute. I will just have a word with the technical team and see if I can get this fixed. Okay, I'll pause the stream for a second and let me get the voice fixed. So guys, is it sorted now or you still have the audio issues? Okay, you are getting it clear? Okay, so okay. Guys, am I audible and clear now? थोड़ा सा क्रोमा भी थोड़ा सा क्रोमा स्पिल हो रहा है. क्रोमा तो ऑडियो आप एक ठीक है. So I'll continue and let's ठीक है. Okay, so guys, I hope it is sorted. If it's still problematic, let me know. In that case, I'll get the class rescheduled if technical issues are not sorted. Okay, now this question, we have a 45-year-old with pain in the chest area, difficulty swallowing, regurgitation of food content, not responding to the antacids, and there is a barium swallow images available. And what do we see here? We see the esophagus appearing like a corkscrew. So this is your typical corkscrew appearance of the esophagus. Corkscrew esophagus. So where do we get corkscrew esophagus? Not in achilles not in juncus diverticulum. We get corkscrew esophagus when you have diffuse esophageal. I'm not getting into the detailed discussion of this topic because in surgery, Dr. Sandeep will be addressing this again, because all these esophageal motility disorders are discussed in surgery in detail. So I will not waste much time here, but be aware that corkscrew esophagus is diffuse esophageal. Okay, next question. A 21-year-old male presented to the clinic with complaints of swelling of his legs. Belly means basically talking about ascites, and also face. His facial puffiness, pedal edema, and ascites. He has been experiencing fatigue and weight gain over past few weeks. His medical history is notable for recent respiratory infection, and after relevant investigation, he is diagnosed with a condition where you will have the pathology similar to the one that is shown in the image. So what is shown in the image? You have a pictorial representation of the glomerulus. And what do we notice here? The only abnormality I'm noticing here is, yeah, there is vacuolation of the podocytes, and most importantly, there is loss of the foot processes of the podocytes. Otherwise, there is no mesangial hypercellularity, there is no sclerosis or damage to the glomeruli. So there is no glomerular sclerosis, mesangial hypercellularity, or any subepithelial deposits. There is no immune complex deposits picturized here. The only change I am noticing is diffuse loss of foot processes. Typical clue for the diagnosis. So what is the diagnosis we are thinking about? Among the given option, nephritis is a vague term. Call it as nephritis, whether it is IgA nephropathy or whether it is minimal change disease. Any inflammation or inflammatory process involving the kidney, you can call it as nephritis. Guys, give me 1 second. Aditya, tell me. माइक को स्विच भी शायद नॉर्मल पे ही है. Okay, so guys, am I audible now? तो अभी अभी ठीक है या अभी भी वो issue? नहीं, अभी अगर दिक्कत है तो फिर क्लास रीशेड्यूल कर लेता हूँ बिकॉज इम्पोर्टेंट टॉपिक्स हैं. ठीक है, तो फिर आई टेल द स्टूडेंट्स दैट. ठीक है. So I hope I'm audible to all of you. Hi folks, I hope I'm audible to all of you. I have the road ones, but ठीक है. So guys, we are facing some technical issues and the team is looking at it. If we can sort this out, we'll continue with the session. If not, I'll get it rescheduled and we will do it again because all the questions included here are extremely important and the key points that we are touching, we are having a high expectation that questions will come from that. So I just don't want to rush through it in presence of some audio disturbance. So let's see if we can get it fixed. ठीक है. Okay. Okay. So as the team has said that they are getting a decent audio. Okay. The team has said that they are getting a decent audio, so then we will continue with the session. Okay. So now, in this question, what are the changes mentioned? Let me reiterate what I was talking about in the question. We're talking about a 21-year-old male who presented with symptoms of fluid overload, you can say. There is swelling of legs. That means this question is talking about presence of pedal edema. There is swelling of belly. That means it is talking about ascites. And there is also swelling of face. So there is facial puffiness. Okay. And then there was mention of some recent respiratory infection. If you think of respiratory infection precipitating renal dysfunction, we think about two conditions. What are those? If there was a upper respiratory tract infection and after that nephritic syndrome, that is patient developing. What are the components of nephritic syndrome? Hematuria with dysmorphic RBCs. Hematuria with dysmorphic RBCs. RBC casts in the urine. Hypertension and periorbital edema. We call this as nephritic syndrome, right? If that occurs, nephritic syndrome occurs within 1 week of the upper respiratory tract infection. Within 1 week of upper respiratory tract infection, then we think of that is suggestive of IgA nephropathy. IgA nephropathy. IgA nephropathy is also called as synpharyngitic nephritis. Means along with the pharyngitis, almost same time it begins. Hematuria begins. along with pharyngitis. It is also called as synpharyngitic nephritis. So that is one possibility. Other is if more than 1 week of upper respiratory tract infection, if the symptoms develop, it is suggestive of post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis. But in this question, there is no talk about hematuria, RBC casts, or dysmorphic RBCs. So that is already going against the possibility of IgA nephropathy or nephritis. I'm left with actually thinking of minimal change disease. And in minimal change, it is called as minimal change disease because we don't have any gross morphological changes on the regular microscopy, regular histopathology. Only under electron microscopy, we can notice that there is loss of the food processes. That's a very typical finding of minimal change disease. So if they are mentioning that there is loss of food processes, it is already talking about minimal change disease. And you know that minimal change disease is the most common. It's exactly petals and places. The recent respiratory infection is just a trap to make you think of IgA nephropathy or post-streptococcal glomerulonephritis. But histopath or the electron microscopy image is very clear. If I had IgA nephropathy, there should be IgA subclass 2 deposits. If it is post-streptococcal glomerulonephritis, the antigen, antibody, or immune complex deposits should be there. It's not there. We only have loss of food processes, which is typical of the minimal change disease. So we should stick to our diagnosis based on the image as minimal change disease. So just because you have minimal change disease and you have nephrotic syndrome, it doesn't mean that you are protected from developing infection. So patient might have gone through an infection, but the real diagnosis here is nephrotic syndrome due to minimal change disease. It is the most common cause for nephrotic syndrome in children. The most common cause for nephrotic syndrome in children is minimal change disease. The most common cause for nephrotic syndrome in adults is diabetic nephropathy. Most common cause for nephrotic syndrome in HIV patients is focal segmental glomerulosclerosis. Okay, now let's go to the next question. We had a question on this topic earlier also. A 60-year-old presented to the emergency with sudden onset of severe pain and swelling in his right knee. So again, it is talking about monoarthritis, right? This is monoarthritis. And any question that is talking about monoarthritis, you are thinking about either gout or septic arthritis or a close differential of gout, also called as pseudo gout. Okay. Now, the pain has started about 2 hours ago and has been increasing in intensity. Microscopic examination of the synovial fluid with polarized light revealed a finding similar to the image given below. What is the diagnosis? So here we are seeing some crystals. What is the shape of the crystals? In the gout, actually, the crystals are made of monosodium urate and they are needle shaped. But here we are seeing rhomboid shaped crystals. You are seeing rhomboid shaped crystals. The crystals are positively birefringent. The crystals which are aligned parallel to the axis of the polarized light are purple-violet, and the ones which are aligned perpendicular to the axis of polarized light are yellow. So in gout, we are getting needle-shaped crystals, which is basically formed of monosodium urate monohydrate crystals. These are formed of monosodium urate monohydrate crystals. While in case of pseudo gout, you get rhomboid shaped crystals. And because the image is showing rhomboid shaped crystals, which are formed of calcium pyrophosphate dihydrate crystals or CPPD crystals. These crystals are made of calcium pyrophosphate dihydrate. So looking at the image, we are going in favor of pseudo gout as the diagnosis here. In rheumatoid arthritis, the synovial fluid might show inflammatory cells but not the crystals. In rheumatoid arthritis, no crystals. In osteoarthritis also, there will be no crystals. Second reason why I'm not considering rheumatoid arthritis as a diagnosis, rheumatoid arthritis generally tends to cause polyarthritis, that too of small joints. So rheumatoid arthritis is a polyarthritis disorder where you will have bilaterally symmetric polyarthritis predominantly affecting small joints of hands. Small joints of hands and characteristically sparing which joints? Usually rheumatoid arthritis spares distal interphalangeal joints. Osteoarthritis is of two types. Osteoarthritis can affect the large weight bearing joints, or it can also affect the small joints. The small joint involvement is called as nodular osteoarthritis. Okay. Now let's go to the next question. A 55-year-old presented to the clinic with persistent cough and shoulder pain that has been gradually worsening over past few months and reports a history of smoking for last 30 years. There is a reduced range of motion and tenderness was noted on the right shoulder. X-ray of the patient reveals a finding similar to the image given below. What is the most likely diagnosis? Okay. So we can see that there is some opacity in the right upper lobe or the apex of the right lung. Now, what it can be? Pulmonary embolism is among the options, probably first thing that I can confidently consider less relevant. Pulmonary embolism leads to focal oligemia. That is, like if right pulmonary artery has developed an embolus, then the blood flow to the right, some part of the lungs on the right side will be reduced. So there will be oligemia or reduced perfusion. And if there is a large clot in the pulmonary artery, there will be an abrupt cutoff of the blood or the pulmonary artery visualization will end abruptly. After that, because there is a clot, you don't see rest of the pulmonary artery. Those findings are not what we see here. So it is less likely to be pulmonary embolism. And even more important, X-ray is not a good investigation for detection of pulmonary embolism. Whatever like Westermarck sign, focal oligemia, whatever we talk about, they're extremely rarely Hampton sound. They're all rarely encountered. The good investigation for pulmonary embolism is CT pulmonary angiography. That's the standard investigation. Okay, so I'm not thinking about pulmonary embolism here. Apart from that, in the question, there is no mention about any risk factor for pulmonary embolism, like already known DVT or long distance travel in a flight on a like the regular tickets, or bedridden state, cancer, recent lower limb or pelvic surgeries where the chance of developing a DVT is high. Those pointers are also not given. Now, why is this not pneumonia? Pneumonia can be lobar. It can affect the upper lobe. But if it is an upper lobe pneumonia, there will be merging of the pneumonia shadow with the tracheal shadow. This is what you call as the silhouette sign. So if there is a lobar pneumonia, the opacity merges with the adjacent structure. Like if it is the right mid-lobe pneumonia, then the pneumonia, the shadow merges with the cardiac border. Upper lobe, it merges with the trachea. Lower lobe, the opacity merges with the diaphragm. You can't differentiate where the diaphragm ends and where the opacity begins. You can't differentiate where the heart border ends and where this opacity begins. If the mid lobe is involved, if upper lobe is involved, the opacity merges with the tracheal margin. That's not what I see here. Second, pneumonia is supposed to have air bronchograms. So within the opacity, you may see some bronchi. So pneumonia shows, if it is lobar, if lobar, it shows two important findings. When it merges, the opacity merges with the adjacent structures, we call it as silhouette sign. And it can also show air bronchogram. The alveoli are consolidated, but bronchi are not. So it should show air bronchogram. And because those findings are not seen here, it is less likely to be pneumonia, less likely to be pulmonary embolism. Tuberculosis, yes, it can affect the upper lobe. So that remains a differential diagnosis. But then tuberculosis does not explain the involvement of shoulder pain and the other thing is tuberculosis often leads to the upper lobe cavitation, and here instead of seeing cavitation, I'm seeing a solid opacity. So that also makes tuberculosis a little less likely. So I'm more left with the lung cancer. Lung cancer especially affecting the upper lobe or apex of the lung is also called as Pancoast tumor. And this tumor is generally invasive, and it is supported by the presence of long-standing history of smoking. It's an invasive tumor which can invade the surrounding structures, and by invading the cervical sympathetic ganglion, it can lead to Horner syndrome. It can lead to Horner syndrome because of the involvement of the cervical sympathetic ganglion, and it can also invade or compress the superior vena cava. So you can have superior vena cava obstruction. So those are extra points that we need to remember. Yes, whenever we are suspecting the embolism, right, there are scoring like Wells score, or there are also newer scoring systems which can assess the possibility of DVT and also possibility of embolism. And if there is high risk, the best investigation is to go ahead with the CT pulmonary angiography. Okay, now what is the next best step in the management of a patient with the below given condition? So what do I notice here in the CT image? You can see this is liver. You can see the vertebral bone. And what are these structures? These are actually kidneys. And what do you notice? Kidneys are large, bulky, and have cystic spaces in them. Kidneys are large, bulky, and are showing cystic spaces in them. Then what should I be thinking about? It's a polycystic kidney disorder, or like if you look at cystic kidneys on imaging, right, what are the conditions you can think of? One is autosomal dominant polycystic kidney disorder, ADPKD, autosomal recessive polycystic kidney disorder, and then maturity onset diabetes in young 5, MODY 5, repeatedly asked MCQ. Which of the following maturity onset diabetes in young carries renal cysts, or which MODY is associated with renal cysts? That's MODY 5. These are the three important cystic kidney diseases that you need to remember. Okay, so MODY 5 will have hyperglycemia plus renal cysts. Okay, ADPKD, they will have renal cysts, then progressive renal failure, progressive decline in GFR, and remember the earliest manifestation of presence of autosomal dominant polycystic kidney disease is development of hypertension because of the loss of renal functions, development of hypertension. Now, autosomal recessive polycystic kidney disease, most of the affected individuals fail to survive the fetal period itself. They generally develop oligohydramnios because the kidneys are dysfunctional, and there is usually early fetal death. So this question is unlikely to be about the autosomal recessive polycystic kidney disease. Either we are talking about ADPKD or MODY 5. And since the question does not talk about anything about hyperglycemia, and remember MODY is again an autosomal dominant condition, so for its diagnosis we need at least 3 generations of diabetes. All those pointers are not there, so MODY is less likely. We are thinking about ADPKD as the most likely diagnosis. So now that we are considering diagnosis as ADPKD, can anybody tell me which of the following is the next best step in the management of the patient? ADPKD is generally due to either mutation inherited as autosomal dominant, it is there in the name, mutation in PKD1 or PKD2 genes, PKD1 or PKD2 genes. Yes, treatment with ACE inhibitors, ARBs, and also vasopressin V2 receptor antagonists Can anybody give me examples for the V2 receptor antagonists? They tend to slow down the disease progression. So ACE inhibitors or ARBs and the vasopressin receptor antagonists can slow down the disease progression. So how do we treat ADPKD? We don't have very effective gene therapy or anything as of now. What we do is we regularly monitor them. We try to treat the complications arising because of the low GFR, like the regular CKD patients. And if they reach a stage where dialysis is the only solution, we have to go ahead with dialysis or renal transplantation. But we can halt or slow down the disease progression to some extent by using ACE inhibitors or ARBs and V2 receptor antagonists like tolvaptan. Very good. Tolvaptan or conivaptan. Conivaptan is given as an IV infusion, so not suitable for daily use. We do use it for treatment of the SIADH or hyponatremia, but tolvaptan is orally available, so can be used here. So option C is going to be our answer. Example, tolvaptan. They also slow down the disease progression. Okay, so next question. What is the initial treatment of choice for a patient who is stable? They have mentioned stable. Stable means we are thinking about BP more than 90 by 60 millimeters of mercury with a finding given in the image below. Electrical cardioversion, intravenous amiodarone, adenosine, none of the above. Okay, so here is the ECG. We have some arrhythmia here. So what arrhythmia is it showing? How do we approach any question on arrhythmia? The approach is simple. First thing we have to see is whether the QRS complex in an arrhythmia is wide or narrow. So let's go through the approach and then we will come back to this question. I've shown you the image, so some of you can tell me what is your diagnosis here. What's the diagnosis? So if the question is on tachyarrhythmia, how will I get to know the question is about tachyarrhythmia? So guys, remember one important tip. If there is an ECG based question, don't think what I should see here. Just see the options. When you see the option, you already get an idea what examiner is expecting from you. If in the option I see ST elevation MI of inferior wall, lateral wall, anterior wall, acute pericarditis, he's thinking about MI and acute pericarditis. So you have to apply the criteria for ST elevation MI and acute pericarditis. In ST elevation MI, you will have convex ST elevation. ST elevation is confined to the affected wall, the leads representing the affected wall. If it is acute pericarditis, you will have concave ST elevation, and it is not confined to one particular vascular territory, and you will also have PR segment depression. So when you see the options, it becomes easy to apply that to the question. So any ECG question, begin by looking at the available option. You get an idea. This ECG image based question is about what. So when I look at the options here, it gives me a clarity that it is about arrhythmias because it is talking about antiarrhythmics and cardioversion. Right, so now I will approach this image from the perspective of arrhythmia. I don't have to see what is happening to ST segment. Is there ST elevation or ST depression, PR depression? I don't have to see all of that. I have to only apply the approach to tachyarrhythmias. And what is the approach? Any question on tachyarrhythmia, the first thing I want to see is the QRS duration. If the QRS duration is more than 120 milliseconds, more than or equal to 120 milliseconds, those arrhythmias will be called as wide complex tachyarrhythmias. You have only two differential diagnoses here. One is going to be ventricular tachycardia, the other one is going to be VFib. But if the QRS duration is less than 120 milliseconds, then you will call those arrhythmias as narrow complex tachyarrhythmias. Now, narrow complex tachyarrhythmias, there are four major narrow complex tachyarrhythmias that you need to know. The first one and the overall most common arrhythmia is sinus tachycardia. Second one is atrial tachycardia. Third one is PSVT. And the fourth one is AFib. Now, how will I differentiate these? If it is narrow complex tachyarrhythmia, you should see the status of P wave, whether they are present, clearly identifiable P waves are present or not. If P waves are present, that means you either have sinus tachycardia or atrial tachycardia, and if the P waves are absent, then it is either AFib or PSVT. Now, how will I differentiate between sinus tachycardia and atrial tachycardia? If P waves are present, If P waves are present, all I want you to do is I want you to see whether the number of P waves is equal to number of QRS. Means each P is followed by a QRS. P is there and each P is followed by a QRS in a patient with high heart rate, tachyarrhythmia. It is sinus tachycardia. Sinus tachycardia. But if number of P is more than number of QRS, what does that mean? It means your atrial rate is higher than ventricular rate. That's why your number of P waves is more. So in that case, I will call it as atrial tachycardia. Atrial tachycardia. If the P is absent, we will see the RR interval. From beat to beat, if the RR interval is varying, it is AFib. It is AFib. And if it is constant, it's not varying, then it is paroxysmal supraventricular tachycardia, most likely AV-NRT subtype. This is a simple approach. This is a bare minimum that you need to know to approach the arrhythmia questions, right? So first thing is see the QRS duration. How do I get to know the QRS duration? In the ECG, horizontally, when you read it, it is representing time, and each small square on the ECG is representing 40 milliseconds. So all I have to see is whether from the beginning of the Q to the end of S, is it accommodated within 3 small boxes or more than 3 small boxes. If it is accommodated within 3 small boxes, less than 120 milliseconds. It is taking 3 or more than 3, then it is more than or equal to 120 milliseconds. So here, 1 small box here, 1 here. So there's only 2 small boxes. So QRS duration is 80 milliseconds. This is not wide. If it is not wide, already I have ruled out VT and VFib. I am left with sinus tachycardia, atrial tachycardia, PSVT and atrial fibrillation. Now for narrow complex tachyarrhythmias, what's my next step? To see whether P is clearly identifiable, present or not. So in this ECG, we don't have a clearly identifiable P wave. Like you see, these are T waves. Because if there is a QRS, there has to be a T. Because the ventricle got depolarized, giving you QRS. So it will get repolarized. So there should be a T. So any positive wave found apart from the QRS, I should always consider it as T first. And then I should look for, is there any additional wave, positive wave that can be labeled as P, and I find nothing. I see 1 T for each QRS and I don't have any additional positive wave. That means P is absent here. So in this image, we are dealing with the narrow complex tachyarrhythmia with absent P wave. And if the P is absent, it is not sinus tachycardia, it is not atrial tachycardia. In sinus tachycardia, atrial tachycardia, P will be present. In a sinus tachycardia, P and QRS will be equal in number. Each P will be followed by a QRS. In atrial tachycardia, the number of P will be more than number of QRS. But both of them have P. Here, I don't have P. So either I have PSVT or AFib. And for differentiation, we have to look at the RR interval, whether it is constant or varying. So one quick look, we know that it is constant. It is not varying. So we have constant RR interval. Constant RR interval. So that makes the diagnosis PSVT. If it was varying, it becomes AFib. Now we can answer this question. What's the drug of choice for the PSVT? A drug of choice is adenosine. And also remember, any arrhythmia, right? A general management protocol is, if there is arrhythmia, is a standard management protocol that you can apply for any arrhythmia per se. First thing you should see is the BP, whether the patient is stable or not. If the patient is not stable, BP is less than 90/60, we have to go for shock. But if it is more than 90/60, you can think about some physical maneuvers. So as first line, you can think about physical maneuvers. Like vagal nerve activation. What can activate the vagal nerve? It can be, for example, Valsalva maneuver or carotid massage. Valsalva or carotid massage. Now, do they work for all arrhythmias? No. These generally work for PSVT, less likely to work for other arrhythmias. So we try this for PSVT, but for other arrhythmias, we directly go to the next step. What is the next step? The next step is the pharmacotherapy. Physical maneuvers only for PSVT. We go for pharmacotherapy. And when it comes to pharmacotherapy, we should have some fair idea what drug I'm using for all these stable patients. So drug of choice for PSVT is going to be adenosine. But if I'm talking about AFib, it's going to be amiodarone. And if it is ventricular tachycardia, it's again going to be amiodarone. It is preferred over lignocaine. Okay. Now similarly, we also have to have an idea about shock. So if you're using shock, there are two types. One is synchronized shock. Shock synchronized with R wave. And that synchronized shock is also called as cardioversion. And when you just give shock not synchronized or not aligned with R wave, that is asynchronous shock or not synchronized, we call it as defibrillation. So defibrillation is only for two arrhythmias. What are those two arrhythmias where we actually go for defibrillation? One of them is going to be ventricular fibrillation. And the second one is VT without pulse. And cardioversion, the synchronized shock for all other arrhythmias. So any other arrhythmia, if the patient is not stable, you are going to give cardioversion. But if it is VFib or VT where pulse is not there, VT with pulse also cardioversion, but pulse is not felt, defibrillation. So what's the approach? Any arrhythmia, stable, physical measures or drugs. Not stable, shock. Shock, two types, cardioversion and defibrillation. For VT without pulse and VFib, defibrillation. For every other arrhythmia, if the patient is not stable, we go for cardioversion. Okay. And then when we go to drugs, we choose drugs based on which arrhythmia we are dealing with. So in this case, we are dealing with a PSVT and they have mentioned patient is stable. So we presume that BP is more than 90/60. So I don't have to go for cardioversion. I have to go with physical measures. There is no mention of physical measures in the option. So then I have to think of next. So what is the next thing after physical measures? It's going to be adenosine. If I also had an option of carotid massage or Valsalva maneuver, then that should be the next step. When that fails, we go for adenosine. Okay. But if I had mentioned that BP is less or patient is unstable, then I would go ahead with electrical cardioversion. Adenosine is a bronchoconstrictor, as one of you pointed. So when you have asthma or COPD, you have to avoid adenosine. So let me add that note. Adenosine is a bronchoconstrictor. Adenosine can cause bronchoconstriction. That's why it is contraindicated in asthma and COPD. So in such cases, as an alternative, what we can use non-DHP calcium channel blockers, CCBs, non-dihydropyridine calcium channel blockers like verapamil or diltiazem, or you can also use amiodarone. Okay. Now let's go to the next question. Here we have a 45-year-old male who presented with history of chronic diarrhea. Now what are the conditions where we can have chronic diarrhea? One of the differential diagnosis is HIV. Okay. When do we call it as chronic diarrhea? We call it as chronic diarrhea if the duration of diarrhea is more than 4 weeks. Chronic diarrhea is equal to diarrhea of more than 4 weeks. More than 4 weeks. So what are the common causes for chronic diarrhea? Today, one of the important causes, HIV enteropathy. So HIV can affect the intestines where you can have chronic diarrhea. It is HIV enteropathy. Then celiac disease, where you have gluten sensitivity, celiac disease. Third, you can have in IBD, especially ulcerative colitis is more likely to cause chronic diarrhea than Crohn's disease. Crohn's disease causes pain, abdomen, and fistula and fissures and strictures than diarrhea. Okay. Then fourth, irritable bowel syndrome. Fifth, tropical sprue. And sixth, Whipple's disease. Okay. Now, among these, tell me which all abnormalities or diseases have histopathological changes. Yes, I can have histopathological changes in inflammatory bowel disease, ulcerative colitis, and Crohn's disease. We have histopathological changes evident. Do I have histopathological changes in the celiac disease? Yes, we can have. In celiac disease, we will have the villus atrophy, crypt hyperplasia, and lymphocytic infiltration. 3 standard histopathological findings. But are they specific to celiac disease? No. So celiac disease cannot be diagnosed on the intestinal biopsy. IBS, no histopathological changes. Tropical sprue, same changes as celiac disease. You can have crypt hyperplasia, villus atrophy, lymphocytic infiltration. So I can't diagnose it based on the histopathology. The only other condition that I can diagnose based on the histopathology is Whipple disease. What do we see? Whipple disease is caused by infection with an organism called as Trophorrhea whippleyi. And in them, on histopath, you will see periodic acid ship or PAS positive macrophages. Not highly specific, but if you have the context sorted that you have a patient with chronic diarrhea, and if you see histopathology showing PAS positive macrophages, it is highly suggestive of Whipple's disease. The other changes like crypt hyperplasia, villus atrophy may be seen here as well, but they are not specific. So this is a potential clue on an MCQ. Okay. So now when I look at this question, they have mentioned clearly that biopsy was performed and it shows PAS positive. So there are plenty of PAS positive macrophages on the biopsy imaging. So in that case, it is going in favor of irritable bowel syndrome. You will have no histopath changes. It's a functional bowel disorder. There is no histopathological changes. You don't see any anatomical or histopathological changes. Whipple disease is where you get PAS positive macrophages. So that's why that becomes our diagnosis. Can anybody tell me now how are we going to treat these patients? Whipple disease, the pathology is not restricted to the intestine. Yes, intestines are affected by the infection, inflammation. There will be malabsorption. But malabsorption is not the only problem. The Trophorrhea whippleyi can also reach the brain and affect the brain. So they can cause cognitive dysfunction, dementia, and death as well. So Whipple disease is not a minor disease. So we need to treat. How do we treat? Infection. So of course, antibiotic. What is the antibiotic of choice for treatment of Whipple disease? Okay. So in ulcerative colitis, you will have crypt abscesses, mucosal friability. Mucosa will be very delicate, right? Hyperemia or redness of the mucosa, and you know that there will be continuous mucosal involvement without skip lesions. And the ulcerative colitis doesn't affect the small bowel, right? It affects only the colon. That's why it is called as colitis. Only colon and rectum. Rectum is the most commonly affected site. But here the biopsy is taken from the small bowel. That already rules out the ulcerative colitis. Yeah, if the Crohn's disease is spoken about, yes, in Crohn's disease we can have involvement of small intestine as well. So in Crohn's disease, you will have skip lesions and you will have full thickness transmural inflammation. There is also possibility of developing fistulae and strictures. Fistulae and strictures. So story is very clear for the diagnosis of Whipple's disease. And when it comes to the management of Whipple's disease, yes, ceftriaxone is the antibiotic of choice. So management, initially for eradication of infection, we use ceftriaxone, but then these are slow replicating organisms. So you also need to have a preventive therapy for a prolonged period. So ceftriaxone, then it should be followed by cotrimoxazole for 1 year. So if they ask you what is the drug of choice, ceftriaxone is the initial drug of choice for eradication of infection. As an alternative, you can also consider carbapenems or carbapenems, that is like meropenem or imipenem. Okay, so that's about Whipple's disease. And I also want you to remember neurovhipples. When there is neurological Whipple's disease, neurological involvement presents with something called as oculomasticatory myorrhythmia. Oculomasticatory myorrhythmia. So it's a condition where patients will have eyeball movements synchronized with the masticatory muscle movement. So patients will be moving the eyeballs constantly, and parallelly there will be contractions of the masticatory muscles like chewing movements and the nystagmus coupled. We call it as oculomasticatory myorrhythmia. This is a pathognomonic finding of neurovhipples. Pathognomonic of CNS involvement in Whipple's disease. So if you get oculomasticatory myorrhythmia, you don't need the biopsy, you don't need to prove the presence of past positive macrophages to call it as Whipple's. You can directly clinically label it as Whipple's. Okay, next question. Which of the following neurological deficit is most commonly associated with the area of infarct shown in the image given below? So you can see an infarct here. And now you should tell me which artery is likely involved here if this part of the brain is showing infarction. What is the blood supply to this part of the brain? Is it middle cerebral artery, posterior cerebral artery, or anterior cerebral artery? What is the blood supply? Okay. So just remember that if I take a sagittal section of the brain, there will be two cerebral hemispheres like this. Okay. So in that case, the corpus callosum is connecting the two cerebral hemispheres. So let us say this is right hemisphere and this is left hemisphere. And let us say I am taking the section through the frontal lobe. So in that case, it is going through the motor area. And in this medial part to little bit of superior part. So this part is where there is a representation of the neurons for the control of lower limb movements, perineum and lower limb movements. The medial and superior part, or you can call it as superomedial part, is where the neurons controlling the lower limb and perineum are present. And then lateral part of the frontal lobe is where you have the neurons representing the upper limb are present. Neurons representing the upper limb are present. Okay. And then inferolateral part, here you have the neurons representing the face. Face has a very large representation in the motor area of the brain. And when we look at the blood supply, the anterior cerebral artery is giving the blood supply to the superomedial part of the cerebral hemispheres. But the place where the face and upper limb is represented, it is getting the blood supply from the middle cerebral artery. From the middle cerebral artery. And for the occipital lobe or posterior part of the brain, we have the blood supply coming from the posterior circulation. So anterior cerebral artery and middle cerebral artery are the ones which are giving the blood supply to the frontal lobe, large part of parietal lobe and temporal lobe. So if you see from the lateral side, I can represent the blood supply like this. You know, the superior part and little on the medial side is where you have the anterior cerebral artery giving the blood supply, and then the rest of the frontal lobe and large part of the parietal lobe is getting the blood supply from the middle cerebral artery. Okay, so when we see this picture, this part is actually the area which is supplied by the middle cerebral artery. So this is your middle cerebral artery territory. So you're having infarction of the middle cerebral artery. So if this is an MCA infarct, what symptoms we can expect? Contralateral weakness of the face and arm and leg to lesser extent, or homonymous hemianopia and macular sparing vision loss. This is typical of the posterior cerebral artery infarction, because occipital lobe is receiving the blood supply from the posterior cerebral artery. Okay, then ipsilateral weakness of the face and arm and leg to lesser extent. Is that true? If right cerebral hemisphere is affected, will I have left-sided weakness or same side? Of course, we know that the motor tract crosses at the lower end of the medulla. So if right brain is affected, I will always have manifestations on the left side. It has to be contralateral. So this can't be my answer. B can't be my answer. Okay, then pure sensory stroke involving face, arm and leg on one side. Yes, the A is the right answer, because this is typical middle cerebral artery territory involvement, and middle cerebral artery is giving the blood supply to that area where your upper limb and face are represented. So if middle cerebral artery gets blocked, this area will have the maximum compromise of blood supply. So we lose functions here more than the lower limb, because the lower limb area is represented by anterior cerebral artery. So you will of course have contralateral, not ipsilateral, weakness of face and arm and leg to lesser extent. Leg is less affected, face and arm is going to be more affected. This is typical finding expected in this patient, because this is an MCA territory stroke. Okay, next question. I think you should be able to get this question from the history itself, even if you don't look at the image. Patient presented with severe headache, and there is a buzzword description given here. He has never experienced a headache of this severity before, right? This is what we call as the worst headache of lifetime, or worst headache ever. And we know the moment this worst headache ever appears in a question, the examiner is talking about yes, the question is about the subarachnoid hemorrhage. And bleeding into the subarachnoid space leads to the enhancement of the basal cisterns. So you are seeing basal cistern enhancement, because all this white thing you are seeing is blood. And where is the bleeding occurring? In the subarachnoid space. That's why you are getting the enhancement of basal cistern. Do I need to know that? No. The moment I see this word, worst headache ever, we know that the question is about subarachnoid hemorrhage. And what is the most common cause for non-traumatic subarachnoid hemorrhage? Trauma can cause subarachnoid hemorrhage for sure, but what is the most common cause for non-traumatic subarachnoid hemorrhage? Yes, it is also called as thunderclap headache. It's also called as thunderclap headache. The most non-traumatic cause for subarachnoid hemorrhage is rupture of berry aneurysms. Rupture of berry aneurysms is the most common non-traumatic cause for subarachnoid hemorrhage. Hypertension generally leads to intracranial or intraparenchymal hematoma, where either bleeding generally occurs in the basal ganglia. To be more precise, the putamen nucleus of the basal ganglia is where most commonly hypertensive bleed occurs. Hypertension is not the most common cause for subarachnoid hemorrhage. We can have it in extreme hypertensions, but most often subarachnoid hemorrhage occurs because of rupture of berry aneurysms. Trauma is also one of the leading causes. Okay, next we have a 70-year-old presents with sudden onset chest pain. ECG shows which of the following diagnosis? Okay, First thing I should see whenever I see an ECG based image is the options. Options tell me whether I should see arrhythmias in this ECG, whether I should see bundle branch blocks in the ECG, or whether I should see MI in the ECG, or whether I should see AV blocks in the ECG. So when I see the options, it is very clear that the options are about MI. So I have to just look at the ST segment. So when we see the ECG, what do we notice? Do I have any ST elevation in lead 1? No. How do I recognize the ST elevation? Remember, the end of the QRS complex is called as the J point. Like the R wave goes up, comes down, sometimes ends or sometimes goes down as S and then ends. End of R or end of S, whichever it is ending with, that point will be considered as J point. This J point will be compared to the PR segment, whether it is above that segment or at the same level. So in lead 1, it will be at the same level. So there is no ST elevation. But when you look at lead 2, this is PR segment. The end of R is the J point, right? Remember, this is Q, going up is R, right? Comes down and ends here. There is no S, it is ending with R itself. So this point becomes J point, and comparison to the PR segment, this point is elevated. So I can say that lead 2 has ST elevation. This is the ST elevation. Lead 2 has ST elevation. What about lead 3? This is P, so this is PR segment, my reference point, and the end of R is here. So this is my J point. J point is above the PR segment. So there is ST elevation in lead 3 as well. And I also noticed the similar ST elevation in AVF. So 2, 3 AVF are the leads which are showing ST elevation. So what is the 2, 3 AVF representing? 2, 3 AVF is representing which wall? So remember, in the ECG, if you're looking at the ECG leads, lead 2, 3 and AVF. 2, 3 and AVF are representing inferior wall. And then V1 and V2 are representing the interventricular septum. V3 and V4 are representing the anterior wall. Very good. Then 1 AVL, V5 and V6 are representing lateral wall. There is no direct representation of the posterior wall, but if you are suspecting posterior wall MI, you can do additional V7, V8, V9 ECG for posterior wall. 12 lead ECG does not have posterior wall representation. We have to additionally do a separate ECG with extra leads. Or if you are thinking about the right ventricle involvement, then we have to do an additional right-sided lead. Otherwise, leads are placed on the left side, but I can place a lead on the right side, which is called as V4R, that is for right ventricle. So standard 12 lead ECG only has representation for the inferior wall, septum, anterior wall and lateral wall. And we should also remember that inferior leads and lateral leads are reciprocal to each other. They are reciprocal to each other. What does that mean? If I have inferior wall MI, there should be ST elevation in inferior leads and ST depression in lateral leads, or vice versa. If I have lateral wall MI, there should be ST elevation in lateral leads and ST depression in inferior leads. We call these changes as reciprocal changes. So if this ECG is actually having inferior wall MI, because according to us, we had ST elevation in leads 2, 3 and AVF. So that means we are suspecting the possibility of inferior wall MI. But if it is truly inferior wall MI, then the lateral leads 1 AVL and maybe V5, V6 should show ST depression. If they're showing, then it is confirmed. So let's look at that. Let me take you through lead AVL. What do you notice in lead AVL? This is my PR segment. In comparison to the PR segment, the end of S is below. This is PR segment, the end of S is below. So this is ST segment. So ST segment is below the baseline. That means you have ST depression in lead AVL. One is not very clear, but AVL is very clear. That means we have reciprocal changes present. So there is ST depression clearly visible in AVL. So that makes the diagnosis as inferior wall MI. Now the question can be built above this, asking you which particular artery may be involved to cause the particular type of MI. So we should have some fair idea about the blood supply of different valves. So when you look at the heart is held in the mediastinum in a slanted way. So we have an inferior wall. This part is inferior wall, and this part is the lateral wall. And what I see on the front is going to be anterior wall. This is anterior wall, and somewhere behind the anterior wall you have this interventricular septum. So inferior wall is represented by leads 2, 3 and AVF. Lateral wall is represented by 1 AVL, V5 and V6. And as we know, anterior wall is represented by V3 and V4. And this is our septum. Septum is represented by V1 and V2. Now, what is the blood supply? Okay, so if you look at the blood supply, you will have a right coronary artery and a left coronary artery. The right coronary artery is the main blood supply to the inferior wall. So inferior wall is getting the blood supply from right coronary artery. So the predominant blood supply to inferior wall is going to be right coronary artery. To some extent, you also get blood supply from the left circumflex artery, but the main supply is right coronary artery. And now what about the anterior wall and septum? The left coronary artery generally divides into two branches. One branch descends down. This is, let us say, left coronary artery anteriorly, and then one wraps around the heart. So one that is going and wrapping around the heart, we will call it as left circumflex, and the one that is descending down, we will call it as LAD, left anterior descending. So you have a left anterior descending and left circumflex. Left anterior descending goes on and supplies the interventricular septum and anterior wall, and the circumflex artery supplies the lateral wall. So your lateral wall is getting the blood supply. Septum and anterior wall are getting the blood supply from the left anterior descending artery, which is also called as anterior interventricular artery, because it is running in the groove between the two ventricles. It's also called as anterior interventricular artery. Lateral wall is receiving the blood supply from left circumflex. Posterior wall and right ventricle receive the blood supply from right coronary artery and little contribution from left circumflex. So I want you to spend 10 minutes and try to remember this, because questions might be built in a way where they ask you to make a diagnosis and then ask you which artery may be occluded in this patient. So if you recognize that this is anterior wall MI, then you know LAD is blocked. If you recognize that there is lateral wall MI, then you know it is left circumflex that is blocked. If you recognize that it is inferior wall MI or posterior wall MI or right ventricular MI, it's most likely RCA, if not circumflex, right? That's going to be our approach to the questions on the myocardial infarction. Okay, next question. We have a female patient who presented with Raynaud's phenomenon. What is Raynaud's phenomenon? Raynaud's phenomenon refers to the vasoconstriction of the distal body parts on exposure to cold, resulting in the pallor, numbness and tingling sensations in the distal parts, mainly hands. She also has joint pain and a skin condition as shown in the image below. Which of the following antibodies can be seen in our patient? So what do you think is this question talking about? What do you think this question is talking about? There are some pigmentary changes in the skin, if you can see. Some red lesions are there. What are these lesions? And there is Raynaud's phenomenon. So what disease actually comes to your mind when you think about Raynaud's phenomenon? No, it is not anti-dsDNA. See, have you anti-dsDNA? Where have you studied? We studied about anti-dsDNA in SLE. In SLE, have we spoken with emphasis on Raynaud's phenomenon? We have spoken about photosensitive malar rash, pleuritis, pericarditis, endocarditis, peritonitis. arthritis, lupus nephritis. We didn't talk much about Raynaud's phenomenon. So where it is, yes, CREST syndrome or the scleroderma or systemic sclerosis. So basically, Raynaud's phenomenon refers to pallor, numbness, and tingling of hands or extremities on exposure to cold. There are two causes for it. One is called as primary Raynaud's phenomenon and the other one is called as secondary Raynaud's phenomenon. Primary Raynaud's phenomenon is also called as Raynaud's disease. So basically here you have exaggerated physiological response to cold. Means normally when exposed to cold we have vasoconstriction. When exposed to warmth or hot environment we will have vasodilatation. That's why when you sit in front of the hot oven we become red because there is vasodilatation, right? You put your hand in ice cold water and remove, it becomes pale because of vasoconstriction. That's normal physiology. But in some individual the response is exaggerated. So just routine exposure to cold itself causes profound vasoconstriction. Like just washing the hand, washing utensils will cause vasoconstriction. For us, it doesn't cause. Only when I put my hand in extreme cold water, I can get vasoconstriction. But for some people, this response is exaggerated. Exaggerated physiological response to cold is called as Raynaud's disease. But if the same manifestations are occurring because of some other disease, we call it as secondary Raynaud's phenomenon. And the most common cause for secondary Raynaud's phenomenon is systemic sclerosis. Systemic sclerosis or scleroderma. Scleroderma is a term that is routinely used for systemic sclerosis. Most accepted technical term is systemic sclerosis. Apart from that, you can also see it in other rheumatological disorders, but less commonly. Like SLE, rheumatoid arthritis, you may be able to see it, including, yes, Sjogren's syndrome. But any MCQ that is talking about Raynaud's phenomenon, the first thing that should strike your mind is systemic sclerosis. Now, the systemic sclerosis has two subtypes. Systemic sclerosis has two subtypes. One is called as limited cutaneous systemic sclerosis. The other one is called as diffuse cutaneous systemic sclerosis. Limited cutaneous and diffuse cutaneous. Now, what do you mean by limited cutaneous? In systemic sclerosis, there will be, as the name says, sclerosis means fibrosis or thickening. There will be skin thickening plus organ fibrosis, fibrosis of organs. Now we are looking at the extent of skin thickening. If the skin thickening is restricted to distal parts, that is hands and forearm, that is distal to elbow joint, then we call it as limited cutaneous. And if the skin thickening extends proximal to elbow joint, then we will call it as diffuse cutaneous. Proximal to elbow joint is diffuse cutaneous. Okay. Now, is it just because there is a different extent of involvement? No. These two behave like two separate diseases. Their behavior is totally different. So, if the skin thickening is extending from the hands all the way up to the elbow joint, it is limited cutaneous. These limited cutaneous patients are associated with what you call as CREST syndrome. They are associated with CREST syndrome. While you don't get that in patients with diffuse cutaneous. If the extent is beyond the elbow joint, it is involving arm, shoulder and all, then it is less likely to be limited cutaneous. It's more likely to be diffuse cutaneous. Now, in diffuse cutaneous patient, there is increased risk of scleroderma renal crisis. Scleroderma renal crisis. What is scleroderma renal crisis? It is a high renin hypertension. They are also at increased risk of developing interstitial lung disease, while these limited cutaneous patients are at increased risk of developing pulmonary arterial hypertension. And both of them are rheumatological disorders, so they will have antibodies. So the classical antibody that we get in limited cutaneous is called as anti-centromere antibody. Anti-centromere antibody. And the antibody that we get in diffuse cutaneous is called as anti-DNA topoisomerase antibody. Or this antibody is also called as anti-SCL70 antibody. It's there in the name, right? SCL means scleroderma. SCL, scleroderma, anti-SCL70 antibody. So exam, they might ask you, giving you the details of limited or diffuse cutaneous and then asking you which antibody may be responsible. So let me try to make it a bit easier for you to remember the antibody and which type of systemic sclerosis it is. If I take a cell and ask you to find centromere, where can you find the centromere? Centromeres are part of the chromosome. So you will find them only inside the nucleus. Can I find a centromere outside the nucleus? No. So can I say that centromere has a limited presence inside the cell? Yes. But what about DNA? Can I find DNA outside the nucleus? Yes. DNA is there in the nucleus because there are chromosomes. But outside the nucleus, you have mitochondria. So within mitochondria, you have circular DNA. So DNA has more diffuse presence in a cell, while the centromere has a limited presence. Its presence is restricted to the nucleus. So that way you can remember that if you think about limited cutaneous, it is anti-centromere. Centromeres have presence only in the nucleus, limited presence, while DNA is diffusely present. So if it is diffuse cutaneous, you think about anti-DNA topoisomerase antibodies, are also called as anti-SCL70 antibodies. Okay, yes. In CREST syndrome, you will have calcinosis. The C here stands for calcinosis, Raynaud's phenomenon. R stands for Raynaud's phenomenon. Esophageal dysmotility. Okay. Sclerodactyly, that is thickening of the skin of the fingers, right? It creates what you call as sclerodactyly, or you can also call this as sausage shaped fingers, sausage digits, because these are inflamed, thickened skin. And T stands for telangiectasia. So in the picture you saw, you are actually seeing those rashes which are basically telangiectasias. Telangiectasia are small vascular anomalies. So in the picture you are seeing telangiectasia. Right? Apart from that, there is mention about Raynaud's phenomenon. So keeping these points in mind, we are making a diagnosis of systemic sclerosis. Now there is no details about antibody mentioned, no details about the extent of skin thickening mentioned. So it could be diffuse cutaneous or limited cutaneous. Presence of telangiectasia pushes me more towards limited cutaneous. Now I have to choose the antibody. What antibody is likely? Anti-Rho antibody is usually encountered in patients with Sjogren's syndrome. It is an antibody for Sjogren's syndrome, and this antibody also correlates. So this anti-Rho antibody correlates with Sjogren's syndrome, and it also correlates with risk of neonatal lupus if it is present in a SLE mother. Neonatal lupus. Anti-Smith, we know it is the most specific antibody in SLE. Anti-dsDNA, of course we know a lot about it. It is the second most specific and second most sensitive antibody in SLE, and also its titers correlate with disease severity as well as the risk of lupus nephritis. So among the given option, only thing that makes sense here is anti-centromere antibody, a typical antibody of limited cutaneous systemic sclerosis. Okay. The next question. Here we have a 20-year-old athlete. He collapses during exercise. Family history of sudden cardiac death is present, and the examination reveals a systolic murmur that increases with Valsalva. Extremely important clue. So what is the most likely diagnosis? So what do you think is the diagnosis? Already they're talking about an athlete who collapsed during exercise. So they have given you potential clues. Also, family history of sudden cardiac death is there. A systolic murmur that increases on Valsalva menu. Yes. Subhaprabha, absolutely right. This question is about hypertrophic obstructive cardiomyopathy. Okay, why not dilated cardiomyopathy? Why not mitral regurgitation? Why not aortic stenosis? Remember, MR also, I have given you a table of murmurs. MR is a murmur where MR is a condition where you get a systolic murmur. You get pan-systolic murmur. Pan-systolic murmur. Okay. Aortic stenosis is also a systolic murmur. You get an ejection systolic murmur. Ejection systolic murmur. And dilated cardiomyopathy is one of the causes for mitral regurgitation. And once you develop mitral regurgitation, it can lead to again pan-systolic murmur. Pan-systolic murmur. So all of the conditions, hypertrophic obstructive cardiomyopathy also produces a systolic murmur. So all of these murmurs are systolic. So what makes you think that this is about HOCM? Yes, one clue is athlete. That's a repeatedly used template by the examiners. Any other clue that makes you think that this is about HOCM? So remember, HOCM is a subset of hypertrophic cardiomyopathy. So we'll talk a little about hypertrophic cardiomyopathy. So what is this hypertrophic cardiomyopathy or HCM? It is an inherited disorder. So if you look at the heart, you have this left side of the heart which gets predominantly affected here in the hypertrophic cardiomyopathy. Let us say this is left ventricle, this is left atrium, and here you will have the mitral valve, here you will have aortic valve. Okay, the place through which the blood moves into the aorta, this place is called as left ventricular outflow tract. Left ventricular outflow tract, the place where blood flows into the left ventricle, this part of the left ventricle is called as left ventricular inflow tract. And this part of the left ventricle, which is a tip, right, this part of the left ventricle is called as the apex. Okay, now what happens in hypertrophic cardiomyopathy is, in hypertrophic cardiomyopathy you develop concentric type of LVH, means you start adding the muscle mass inwards, and this concentric type of LVH is associated with asymmetric septal hypertrophy. Asymmetric septal hypertrophy means you start adding the muscle inside, and when you start adding the muscle inside, you cause the hypertrophy of the septum more than the free wall of the left ventricle. So the septum starts enlarging more inwards in comparison to the rest of the ventricular wall. So septum becomes more and more hypertrophied. So this asymmetric septal hypertrophy results in eating up the space available for the flow of blood from left ventricle to aorta. So it leads to left ventricular outflow tract obstruction. And once the left ventricular outflow tract obstruction occurs, we call it as hypertrophic obstructive cardiomyopathy. So it starts with hypertrophy just, but one day it will cause hypertrophic obstructive cardiomyopathy. And when blood passes across this narrow left ventricular outflow tract, there will be turbulence created and you hear that as a murmur. And when blood passes across this left ventricular outflow tract during systole, when the ventricle is contracting and trying to eject the blood, that's why you are getting a systolic murmur. And isn't it similar to aortic stenosis? In aortic stenosis, the aortic valve is narrow, it is obstructing the flow of blood. Here, there is no problem in the aortic valve, but just beneath the aortic valve, there is obstruction. So HOCM is also known as subvalvular aortic stenosis. Subvalvular aortic stenosis. So murmur is going to be similar to aortic stenosis murmur. So what kind of murmur we are expecting in HOCM? We are expecting an ejection systolic murmur. Ejection systolic murmur similar to AS. Similar to aortic stenosis. But what helps me to differentiate the aortic stenosis murmur from the HOCM murmur is there are two conditions. Remember, there are some rules or dictums of murmurs. The first rule that I want you to remember is all murmurs increase on increasing venous return. So if I make more blood to reach the heart by increasing the venous return, more the blood, more the turbulence across the wall, more the murmur. So all murmurs means AS, AR, PS, PR, TS, TR, MS, MR, all murmurs increase on increasing the venous return. But there is an exception to that. What are those exceptions? Two of them. One of them is HOCM. The HOCM murmur actually decreases on increasing the venous return or vice versa. Another one is mitral valve prolapse. Now, which maneuvers increase the venous return? Venous return can be increased by squatting. When you squat, the calf muscles contract and push more blood to the heart. Or also by passive leg raising. So when someone raises the leg of the patient, the blood from the leg flows towards the heart. So if more blood comes to the heart, more flow across the valve and the murmur increases. But HOCM and MVP behave as exception. So any question that is talking about Valsalva maneuver, squatting, passive leg is probably be a question on HOCM or mitral valve prolapse. And all murmurs decrease on decreasing venous return. But the same conditions act as exceptions. So what are the exceptions? HOCM and mitral valve prolapse and mitral valve prolapse. So what condition decrease the venous return? When you do Valsalva, you increase the intrathoracic pressure and you prevent blood from flowing into the heart. Valsalva maneuver and standing. If you stand, gravity pulls more blood into the lower limb and less blood flows into the heart, right? There's another rule I want you to remember, that all right heart murmurs increase on inspiration, because right side of the heart gets more blood during inspiration. So all right heart murmurs increase on inspiration, and same way all left heart murmurs. So if the murmur is originating from aortic valve or mitral valve, they increase on expiration. That's why AS murmur, AR murmur, MS murmur, MR murmur is best heard in expiration. There's one exception to this right-sided murmurs increasing on inspiration, and that is pulmonary ejection click. Pulmonary ejection click. So if you have PS, you will have a pulmonary ejection click that does not become loud on inspiration. And when the right-sided murmurs become loud on inspiration, we call this as De Carvalho sign. It is called as De Carvalho sign. Right-sided murmurs becoming louder on inspiration. Okay, clear? So now can we apply this understanding to the question and figure out what is the right answer? All these are systolic murmurs. Now I have to see whether it is behaving according to the rule or as an exception. So the maneuver is increasing when Valsalva is done. The murmur is increasing. Valsalva is associated with decreased venous return. So all murmurs decrease on decreasing the venous return. So if it was AS or MR or dilated cardiomyopathy which causes MR, I am expecting the murmur to decrease. But here it is behaving as an exception. It is increasing. So if the murmur increases on decreasing the venous return, either it should be about mitral valve prolapse or HOCM. So here there is no talk about mitral valve prolapse. So I will go ahead with hypertrophic obstructive cardiomyopathy as the diagnosis. Extra points to note about HOCM is, in HOCM, you will have one more echo finding. What is that finding? You will also have systolic anterior motion or SAM. Systolic anterior motion or SAM of anterior mitral leaflet. So what is this? You know, here in this interventricular septum, you will have a papillary muscle and its chordae will be attached to the mitral leaflet. Now that the interventricular septum is hypertrophic, it can pull the mitral leaflet with more force than usual. So that makes the mitral valve leaflet move anteriorly towards the interventricular septum. This is what we call as SAM, sometimes used in the exam as a clue by the examiners. So if they're talking about asymmetric septal hypertrophy, or like usually abbreviated as ASH, or if they are talking about SAM, or sometimes because of this asymmetric septal hypertrophy, the LV becomes banana shaped. So if they are talking about banana shaped left ventricle, the question is about HOCM or hypertrophic cardiomyopathy. What extra points I want you to know? HOCM or hypertrophic cardiomyopathy are the most common cause. HOCM is just one subset where hypertrophy has resulted in obstruction to the left ventricular outflow tract. Is the most common cause for sudden cardiac death in young individuals and athletes. Okay, so any question that talks about athlete young deaths may be talking about HOCM, and in this question we had that information as well. So we are more than sure that this question is about hypertrophic obstructive cardiomyopathy. Why are we getting banana shaped left ventricle? Because the free wall starts thickening, interventricular septum starts thickening, leaving the left ventricle appear like a banana. Okay, now let's take one more question. A patient has been diagnosed with some valvular heart disease, they have not mentioned which one, and has water hammer pulse, displaced heaving apex beat. On auscultation, he has an early diastolic murmur. Okay, now tell me, what is the diagnosis? Early diastolic murmur. What are the diagnoses we have? We have put a table earlier, right, for the murmurs. So if you by heart that table, you will be able to deal with a lot of questions coming from it. There are two conditions where we can have an early diastolic murmur. What are those two conditions? One of it is AR, the other one is PR. So in AR and PR, you will have a decrescendo early diastolic murmur. Okay. Now what is this question talking about? There is an early diastolic murmur, plus it is giving you one more important clue, a pulse called as water hammer pulse. So if you see a question on water hammer pulse, you know it is talking about aortic regurgitation. So this is a question on aortic regurgitation. So you get water hammer pulse. In aortic regurgitation, you also get early diastolic murmur in aortic regurgitation. But what is he asking us actually? Cardiologist who has seen him points out that the skin at the bottom of the nail bed is flushing and paling when pressure is applied to the tip of the nail. What is the sign called as? So basically in aortic regurgitation, what happens? In aortic regurgitation, there will be increase in systolic BP and there will be decrease in diastolic BP, creating a wide difference between systolic and diastolic BP, right? What do we call it as? We call it as wide pulse pressure. Wide pulse pressure. And when the pulse pressure becomes wide, one of the characteristic finding of wide pulse pressure is the pulses become visible. You will have visible pulsations. Normally pulses are not visible. Like we have radial artery which is so superficial, but we don't see the pulses because the size change of the artery in systole and diastole is very minimal. Systolic distance, diastolic narrows, but the size change is very minimal, so we can't see it pulsating. I'll tell you what is exactly happening. If you see my hands, I have tremors, but most of you can't see because the position change of this finger is very minimal. Until and unless you closely observe, you can't see because the position change is minimal. But what if I was drunk with alcohol and I had the cerebellar tremor, that is action tremor. The moment I try to grab something, I will be shaking. That tremor you will be able to see because the position change is wide. Normally arteries are expanding and becoming smaller, expanding in systole, becoming smaller in diastole minimally. So this minimal change human eyes can't see. But once you increase the systolic BP, the pulse of the arterial diameter becomes significantly expanded during systole. and diastolic BP is less, so it collapses during diastole. So the size change is very obvious. Our eyes can pick it up. So pulses become visible. And these visible pulses are given different names. Like for example, if the brachial artery pulses become visible, we call it as locomotor brachialis. If the carotid artery pulsation become visible, you call it as dancing carotid or Corrigan's sign. Okay. So now they are asking that there will be also visibility of the nail bed capillary pulsations, and what do you call it as? So this alternating flushing is because a lot of blood is gushing into the capillaries during systole, and diastole the flow is dropping because the diastolic pressure is less. So that's basically visible nail bed capillary pulsations, and we call that as Quincke's sign. So nail bed visible pulsations is Quincke's sign. Okay, Carvalho sign I just told you. Increase in right-sided murmurs is called, on inspiration, is called as Carvalho sign. Okay, what is lighthouse sign? Same thing, the visible pulsations on the forehead, or in other words, you can say that if more blood gushes into the forehead during systole, it becomes red, and diastole flow drops, so it becomes pale. So you will have alternating blanching and flushing, or you can say paler and flushing of forehead is called as lighthouse sign. All of these are signs of AR except this Carvalho sign, which is a sign of increase in murmur of right side, that is a PSPR or TSTR on inspiration. What is de Musset sign? Sudden increase in blood during the systole to the head and neck region generally pushes the head forward because too much blood is gushing into your head and neck blood vessels during systole. But diastole, the flow drops back towards the heart in AR, so head goes back. So patients are constantly bobbing their head. So it is the head bobbing which is called as de Musset's sign. All of these are, except A, all of these are peripheral signs of AR. These are peripheral signs of AR. Now among this, what's the answer? Quincke's sign is the visible nail bed pulsations. Okay. Now we'll take one more question and then we'll wind up for today. I'll try to have one more session trying to cover few more questions so that we could touch all the important areas of important systems. Okay, so this is a question. The given sagittal brain section, the colored region corresponds to paracentral lobule. What structures would be impacted by a lesion in this particular area? Scapular region and neck, trunk and shoulders, perineum and leg, or face and neck. So what you're seeing is the medial surface of the brain, like two cerebral hemispheres. Let's say these are two cerebral hemispheres. Okay. What you're seeing, if this is a brain, two cerebral hemispheres, what you see from the side is the lateral surface, but they have opened it up and they are showing you the medial surface. And when you see the medial surface, what do you notice? The superior medial part is where there is involvement, right? This is what you call as paracentral lobule. And what is represented here? Yes, it is the perineum and the lower limb, which is represented here in the motor area. On the other side, the lateral side, lateral inferior side, is where you have the representation of the upper limb and face. So if this gets affected, you will have predominant involvement of perineum and leg. Perineum and leg. Okay. And you also know that the blood supply to this area comes from anterior cerebral artery. Area comes from anterior cerebral artery. Yeah, so this is the lower limb and perineum representation on the motor homunculus. The medial and superior surface, that is paracentral lobule. The lateral surface is where you have the upper limb, and lateral inferior surface where you have the face represented. Okay. So we'll take one last question and then we'll wind up for now. Okay, so here we have a 28-year-old IV drug abuser presented with fever and new onset holosystolic murmur at the left lower sternal border. Blood cultures grow Staphylococcus aureus. What is the most likely diagnosis? We have given a lot of clues here. It's a 28-year-old IV drug abuser. He has fever and new onset holosystolic murmur at the left lower sternal border. So ignore the diagnosis. Tell me which valvular lesion has occurred here. We have discussed about the valvular heart disease, the murmurs. So which valvular heart disease you are thinking? So they are telling you the area, right? So which area it is? Yes, the diagnosis is right for most of you, but which area it is? Left lower sternal border. Is it mitral area, aortic area, pulmonary area, or tricuspid area? And holo means pan. So where do you get pan systolic murmur? Okay. Remember, the holosystolic or pan-systolic murmur is encountered in two conditions. What are those two conditions? Number one is mitral regurgitation. Number two, tricuspid regurgitation. And this area is actually tricuspid area. That means we are getting a pan-systolic murmur from tricuspid area. So what becomes the diagnosis? Yes, this is a case of tricuspid regurgitation. Ventricular septal defect is another condition where you can have pansystolic murmur. Now here it is heard from the tricuspid area. So that makes me think of tricuspid regurgitation. Is it consistent with the clinical picture? Yes, he is an IV drug abuser. IV drug abusers are prone to develop right-sided infective endocarditis. Otherwise, infective endocarditis predominantly affects the mitral valve. So in infective endocarditis, most commonly affected valve is mitral valve, followed by aortic valve. What happens to the mitral valve? You develop mitral regurgitation. You can also develop aortic regurgitation. So you can develop MR and AR. So MR is the most common valvular lesion. But the extra point here is, in IV drug abusers, they tend to develop, in IV drug users, there will be right-sided infective endocarditis. And in that case, the most commonly affected valve will be tricuspid valve. Tricuspid valve. And what happens to the tricuspid valve? You tend to develop tricuspid regurgitation. So in this question, it is consistent with it. An IV drug abuser presenting with the murmur in the tricuspid area, which is pansystolic. So we have already concluded it as tricuspid regurgitation, and blood culture is also showing that there is Staphylococcus aureus, which is the most common cause for right-sided infective endocarditis in IV drug abusers. So everything is consistent. So we can go ahead with infective endocarditis as the diagnosis. It's not viral myocarditis. Viral myocarditis leads to heart failure. It can lead to heart failure because inflamed myocardium may not be able to contract well. So you develop heart failure. Patient presents with acute heart failure, not with the tricuspid regurgitation. If there is pericardial effusion, you can have muffled heart sound. And if it is severe, it can lead to cardiac tamponade, where you will end up with hypotension and raised AV. You don't get this tricuspid regurgitation in pericardial effusion. Rheumatic heart disease most often leads to mitral valvulitis, not tricuspid, followed by aortic valvulitis. In rheumatic heart disease, the most common manifestation, because mitral valve is affected, so you will end up with mitral stenosis. Mitral stenosis is the most common lesion that we get in rheumatic heart disease, followed by MR, followed by AR. Okay, the right side involvement in rheumatic heart disease is less common. Yeah, it can cause, followed by tricuspid stenosis, followed by tricuspid regurgitation, and the pulmonic valve is least commonly involved in rheumatic heart disease. But here, patient does not have the left heart involvement. Also remember that even if I have TS or TR, because of rheumatic heart disease, invariably mitral stenosis will be there. So mitral stenosis leads to, like, starts with mitral stenosis. Then eventually, as more and more episodes of rheumatic fever occur, there may be involvement of aortic and then tricuspid valve. You will not have an isolated tricuspid regurgitation or stenosis without mitral stenosis in rheumatic heart disease. So this is not going to be my answer. This is not my answer. This is not my answer. Infective endocarditis remains my answer. Okay, fair. So I will take 5 minutes on the ABG also, and then we will wind up today. Okay, because yeah, ABG based questions are pretty common. So we will see how to approach ABG. I'll keep it simple because questions are actually simple. Only thing is the wording is confusing. So remember, in our body, we have constant production of acid. What is acid? Acid is a substance which donates H plus ions. Anything which is capable of donating H plus ion. So what is acid? An H plus or a proton donor is called as an acid. And anyone who can accept an H plus is called as a base. So what is a base? Base is a proton acceptor. So in human body, we constantly produce lot of acid, right? And one of the major contributor for acid production is carbon dioxide. Why carbon dioxide is an acid? When carbon dioxide gets dissolved in water, it becomes what you call as carbonic acid, H2CO3, which is carbonic acid. And this carbonic acid can dissociate. This can dissociate into H plus plus HCO3 minus. So it can act as a H plus donor. H plus donor. So that's why carbon dioxide is an acid. And we produce carbon dioxide from each and every cell every minute because of the metabolism, right? So body is challenged by acid production. Now I have to maintain a normal pH. So what's the normal pH? Why I need normal pH? Because for all the cells to function or carry out all their biochemical reactions, the pH should be in the normal range, which is 7.35 to 7.45. If the pH goes below 7.35, we will call it as acidosis. And if it goes beyond 7.45, we will call it as alkalosis. Okay. So what we have learned so far, carbon dioxide is our major acid. And what is a major base in the body? The major base in the body is, one is ammonia, the other one is bicarbonate. So bicarbonate is one of our major base. So carbon dioxide is an example for acid. And if you ask me an example for base, then it is bicarbonate, because bicarbonate can bind with this H plus. It can accept H plus. So an H plus acceptor is a base and H plus donor is a acid. Okay. Now, this is the normal pH that I need. Okay. And this is achieved by maintaining the relative values of PaCO2 and bicarbonate normal. So what's the normal PaCO2? 35 to 45 millimeters of mercury. And what's the bicarbonate value? 22 to 26 millimoles per liter, or you can also call it as milli equivalents per liter. So when my PaCO2 and bicarb are held in this range, I will get the pH of 7.35 to 7.45, perfectly normal for normal physiological functioning of cells. Now imagine a condition where there is increased carbon dioxide in the body. Why will it increase? Let's say carbon dioxide clearance is a function of respiratory system, and there is some problem with respiratory system, like I have COPD, I am not able to exhale the carbon dioxide out. So carbon dioxide clearance is not occurring, body is accumulating carbon dioxide, right? So in that case, the blood carbon dioxide levels start increasing. So what is increasing? Increasing carbon dioxide means increasing acid. So what happens to the pH? pH starts dropping down. pH starts dropping down. So let's take up that example of COPD. So in COPD, there will be increase in PaCO2. PaCO2 increase means there is increase in acid. So if the acid increases, pH decreases. Now this will be considered as the primary abnormality. This is the abnormality that is occurring in COPD. Now body will try to keep the pH normalized. What it can do now? Carbon dioxide we are not able to clear. Acid we are not able to clear. We are accumulating. How will I get the pH back to normal? See, excess acid has tilted the pH towards acidosis. Now what should I do with the base? Decrease the base or increase the base? More acid means pH is tilted towards the acidosis. Yes, acidosis drops the pH. So carbon dioxide accumulation has decreased the pH. Now I want to get the pH back to normal. Just think about it. Like we have a weighing scale, on one side carbon dioxide, another side bicarbonate. And when they are in right balance, you have the right pH. But if the carbon dioxide increases, how do I get the pH back to normal? What should I do with the base? Excrete or get more base? Not decrease. See, remember, this is the point I want to stress upon. So imagine that we have this one weighing scale in which on one side we have carbon dioxide and the other side we have HCO3 minus. So if carbon dioxide increases, the scale is tilted on this side, right? So if I remove the bicarbonate on the other side, what will happen? The scale will be more tilted towards the acid. Yes, see, I have to basically neutralize. If there is excess acid, I have to neutralize. So I have to add more base. So if acid increases, to compensate, base increases. Or if base decreases, to compensate, acid decreases. So if PaCO2 is increasing as a compensatory change, I have to increase HCO3 minus. So that is basically trying to increase the base. By increasing the base, pH can be now increased. So I can tilt the pH towards normalcy, right? So any acid-base disorder, there is a primary abnormality and a compensatory change. And the point to note is primary abnormality and compensatory change follow the same direction. Change follow same direction. Very important point. Means if acid is increasing, that's a primary abnormality, then base also increases to get the pH normalized. If acid is decreasing, base also decreases to get the pH normalized. If base is increasing, acid increases. Base is decreasing, acid decreases. How do we increase or decrease? If I have to increase or decrease carbon dioxide, respiratory system comes into picture. If I have to increase or decrease bicarbonate, kidneys come into picture. So kidneys can excrete more bicarbonate or reabsorb more bicarbonate as per the need. Lungs can increase carbon dioxide clearance or decrease carbon dioxide clearance as per the need. So if the primary abnormality is change in carbon dioxide, like increase PaCO2 or decrease PaCO2, if that's the primary abnormality, we will call it as a respiratory disorder. And if the primary abnormality is change in bicarbonate, then we will call it as metabolic disorder. Okay, this is clear. Now I will give you an example and we will take it through the examples. Let's say there is an ABG, or let's say the same patient. Okay, if I give you the same patient, you will easily make the diagnosis. So let's take the ABG problem. So here I have a patient whose pH is 7.38 and his partial pressure of carbon dioxide in the arterial blood is 80 millimeters of mercury and his bicarbonate is 32 millimoles per liter. Now tell me, is there any acidosis, alkalosis, or is it normal? You know the normal pH, you know the normal carbon dioxide, you know the normal bicarbonate. Edla Akhil Reddy, yeah, a very good point, right? See, the basic logic of compensation is same. So in the words, when you have metabolic acidosis, what do? You give more acid? No, you give base. So if body is accumulating acid, body also need to add base to get the pH normalized. That's why we say the primary abnormality and the compensatory change follow the same direction. Savasan, absolutely right. So I will give you an approach to APJ. So what you should do whenever we have to deal with such questions is, first thing you should see on any ABG based question is the pH. Now pH can be in the normal range or outside the normal range. Normal range means 7.35 to 7.445 as in this question, or it can be less than 7.35 or it can be more than 7.45. We already know that if it is less than 7.35, it is acidosis. And if it is more than 7.45, it is alkalosis. It is alkalosis. Okay. But if the pH is in the normal range, there are two possibilities. Okay. Either you have no acid-base disorder at all. It's perfectly normal ABG report. Or you may be having an acid-base disorder. And the compensatory change might have corrected the pH back to normalcy. Like in this case, PaCO2 was increased because of your respiratory system's failure to clear carbon dioxide in COPD. And because of that, your pH was dropping. But increasing bicarbonate, if it pushes the pH back to normalcy, decreasing pH countered by increasing pH with the bicarbonate, then pH may come back to normal range. So that's also a possibility. So if the pH is in normal range, there are two possibilities. Either no acid-base disorder or the compensatory change has completely compensated and normalized the pH. So how will I get to know whether it is no acid-base disorder or there is fully compensated acid-base disorder? You have to see what is happening to PaCO2 and bicarbonate. If those values are also normal, means pH is also normal, bicarbonate and carbon dioxide, your acid base are also normal, that means there is no acid base disorder. Acid base disorder. But if the PaCO2 or bicarb are abnormal, when I say abnormal, it may be decreased or increased. They're not normal for sure. If there is abnormal, then you have an acid base disorder. The pH has been normalized by the compensatory change. So then you can make a diagnosis of fully compensated acid base disorder. Fully compensated acid base disorder. So here pH is normal, 7.35 to 45 range. So direct acidosis or alkalosis, I cannot come to that conclusion. But when I look at the internal values, PaCO2 is normal 35 to 45. That is clearly increased. And if I see the bicarbonate, 22 to 26 is normal. That is also increased. So they are not normal. They are increased. Only pH is normal. So that means there is a hidden acid-base disorder which has been compensated to normal pH by the compensatory change. Now I have to figure out what is the primary abnormality and what is the compensatory change. That's the second part. But here we can clearly agree that we have some fully compensated acid-base disorder. Fully compensated acid-base disorder. Which one is that? We have to figure that out. But it is fully compensated. Okay. We'll take another problem. In this, we have a pH which is 7.22 and PaCO2 which is 20 millimeters of mercury and bicarbonate which is 10 millimoles per liter. So at least can anybody tell me what is the diagnosis here in this ABG? pH is less than 7.35. So here, whatever is the diagnosis, there is certainly an acidosis present. Whether it is metabolic or respiratory, we need to figure out, but there is an acidosis present because pH is less than 7.22. Now, how will I decide this acidosis is respiratory or metabolic? So once you come to the conclusion from here, this is our step 1. Look at the pH and decide whether there is acidosis or alkalosis, and if pH appears normal, decide whether it is fully normal or there is a compensated acidosis or alkalosis. Once that is done, step 2 is to follow Rome or ROM's criteria to decide the acidosis or alkalosis that we are getting is respiratory or metabolic. So what we do here is we assign a direction to the pH and PaCO2. You have to just assign a direction based on what is happening to pH. pH is decreasing or increasing here. PaCO2 is decreasing or increasing here. And based on that direction, if pH and PaCO2 both are in the same direction, then according to ROMS, respiratory, opposite, metabolic, same side. If both are in the same direction, whatever abnormality you got, acidosis or alkalosis, is metabolic. If pH and PaCO2 are in the same direction. If they are in the opposite direction, then you have respiratory. So in this particular example, the second example, pH is less than 7.35, so there is acidosis. Now I have to assign a direction to the pH and PaCO2. We are not assigning the direction to bicarbonate. We are taking into account pH and PaCO2. So here what is happening to pH? Yes, it is decreased. And what is happening to PaCO2? Normally 35 to 45. That is also decreased. So that means both are in the same direction. Both are in decreasing direction. So if they are decreasing, it is metabolic. It is metabolic. So this case was very clear. You have a metabolic acidosis. In metabolic acidosis, they also ask a next level question. We will go there also. But before that, we will figure out this, because nowadays most questions on ABG are either metabolic acidosis with the calculation of anion gap, or it is a compensated acidosis or alkalosis. So now how will I decide? Here we have fully compensated. First thing I have to decide is acidosis or alkalosis. Second, I have to decide whether it is metabolic or respiratory. So when pH is normal, how will I figure out whether we have acidosis or alkalosis? So if the pH is normal, we are using the 7.4 as the cutoff line. 7.4 as the cutoff line. So in fully compensated acidosis, you will use 7.4 as the cutoff line if it is fully compensated. If it is lesser than 7.4, you can call it as, so here 7.4 is the cutoff line. So on this side of the 7.4, less than 7.4, you will call it as acidosis, and if it is more than 7.4, you will call it as alkalosis. Less than 7.4 acidosis, more than 7.4 alkalosis. Where we are using 7.4 as a cutoff? If the pH is in the normal range. If it is outside the normal range, it's a straightforward thing. Less than 7.35 acidosis, more than 7.45 alkalosis. There's no doubt about that. But if it is fully compensated, where pH is normal but bicarbonate PaCO2 values are abnormal, then you will use 7.4 as a cutoff. So now tell me, what is it here? Clearly pH is less than 7.4. So in that case, this will be considered as a acidosis, fully compensated acidosis. Okay, so this is a acidosis. Now I have to decide whether it is metabolic or respiratory. It is less than, yes, it is less than 7.4, so it is acidosis. Now for the acidosis versus alkalosis, we are following the same ROMs again. Same ROMs again. So we have to assign a direction to the PaCO2 and pH, and then based on that decide whether it is respiratory or metabolic. But remember here, the direction assigned to pH is taking into account 7.4 as cutoff. So in comparison to 7.4, the pH is decreased and PaCO2 is increased. They are in the opposite direction. They are in the opposite direction. So what becomes my answer? It is a fully compensated respiratory opposite. So it becomes respiratory acidosis. So it's a fully compensated respiratory acidosis. Okay. Now, what should be the full naming of this disorder? And also we'll talk a little more about this fully compensated, but what should I label this as? Metabolic acidosis. But what about compensation? Is there compensation present or not? Okay, so give me just 2 minutes. Once you come to this conclusion that it is metabolic or respiratory acidosis or alkalosis, using this algorithm, you have to figure out what is the primary abnormality. So in metabolic, primary is bicarbonate. In respiratory, primary abnormality is carbon dioxide. That is logical, right? So in the second example, what's the primary abnormality then? What's the primary abnormality? Metabolic. So primary abnormality is low bicarbonate. Decreased bicarbonate is the primary abnormality. And because bicarbonate decreased, to compensate for it, PaCO2 is expected to decrease. Is it decreasing? Yes, here it is decreasing. So that's our compensatory change. Decreased PaCO2 is the compensatory change or a secondary manifestation. But decrease was not sufficient to get the pH normalized. That's why we are still in acidosis, but compensation is occurring. So can I call it as partially compensated metabolic acidosis? Yes, we will call it as partially compensated metabolic acidosis. But if I had bicarbonate less, but PaCO2 is not changing, it's normal. That means the respiratory system is not compensating. In that case, I would have called it as uncompensated metabolic acidosis. But here, the PaCO2 is moving in the direction of bicarbonate. Bicarbonate decreased, so PaCO2 is also decreasing. So that's why you can call it as partially compensated. If pH is normalized, then only you will call it as fully compensated. So in the example 1, what is the primary abnormality? What is the primary abnormality? If it is respiratory, primary abnormality will be carbon dioxide. So I should blame carbon dioxide here. So this is a primary abnormality and compensatory change is going to be bicarbonate. So carbon dioxide increase, your respiratory system failed to clear the carbon dioxide. So to compensate for that, bicarbonate increased, and bicarbonate increase was sufficient enough to pH to get normalized. That's why you have got a pH normalized. So that's why we are calling it as fully compensated respiratory acidosis. Here we have partially compensated metabolic acidosis. Okay, so let me summarize again. Whenever you get an ABG, first thing you should do is look at the pH. Less than 7.35 or more than 7.45, you know it is acidosis or alkalosis. Next, you decide respiratory or metabolic by looking at the ROMs. You assign a direction to pH and PaCO2. If they are in the same direction, whatever was your abnormality, that will be labeled as metabolic. If they are in the opposite direction, you will label it as respiratory. And in that case, you will figure out which one is the primary abnormality and which one is the compensatory change by looking at respiratory versus metabolic. If your conclusion is that you have a metabolic disorder, then the primary abnormality is bicarbonate, and the change that you are seeing in the carbon dioxide is compensatory change. If your decision is that this is a respiratory abnormality, then the primary abnormality is carbon dioxide, and the change that you are seeing in the bicarbonate is the compensatory change. Okay. But if the pH turns out to be normal, that does not rule out an acid-base disorder. It could still be fully compensated acid-base disorder. So that's why you will see the internal values. If bicarb or PaCO2 are abnormal, you still have an acid-base disorder. If they are also normal, no acid-base disorder. But if bicarb or PaCO2 turn out to be abnormal, then there is an acid-base disorder which is fully compensated. That's why you have a normalized pH. Now to decide whether to label it as acidosis or alkalosis, you will use 7.4 as the cutoff. Less than 7.4, you will now call it as acidosis, and more than 7.4, you will call it as alkalosis. So once you come to that conclusion that, okay, here we have a fully compensated alkalosis or acidosis, you will again follow the ROMS criteria to decide whether it is metabolic or respiratory. Okay. And once you have decided that it is metabolic or respiratory, you know how to assign primary abnormality and the compensatory change. Primary abnormality in respiratory is respect to carbon dioxide. In case of metabolic, it is bicarbonate. The other change is compensatory change. Okay. Now finally, if it is a case of okay, so Winter's formula, so far FMG they have not asked the question, but yeah, they might touch to calculate the appropriateness of the compensation. So if you have time, you can go through that. What I'm expecting is, following the tradition, most of the questions are going to be either about anion gap calculation, or they are going to be about terminologies, whether it is partially compensated, fully compensated, what is the primary abnormality, there is compensation occurring or not. Those are the questions that are asked. So we'll spend 2 more minutes on the anion gap and then we will wind up for today. And this anion gap calculation only applies for metabolic acidosis. So if you have metabolic acidosis, there is also another concept called delta gap, but they won't go to that extent, because for me to travel through all these steps and then go to delta gap for calculation, it will take 3 to 4 minutes, and it is not morally right on part of the board to ask a question where calculation itself takes 3 to 4 minutes. So they have never asked a question on that. That's why, like, they also have a moral obligation to make sure that the question can be answered by at least 50% of the students in 1 minute. So they can't accommodate so much of mathematical equations. So keep it simple. So if you have a metabolic acidosis, you have to calculate anion gap. Anion gap. How do you calculate anion gap? Anion gap is defined as the difference between measured cations and measured anions. Measured cations minus measured anions. Normally there should be zero difference, but we are not measuring all cations and all anions, so we get some difference. What are the major measured anions, cations in the body? The major measured cation is sodium. And what are the major measured anions? We have bicarbonate and chloride. Bicarbonate and chloride. So when you subtract the sum of bicarbonate and chloride from the sodium, you will get the anion gap. So the normal anion gap is 8 to 12 milliequivalents or millimoles per liter. That's the normal anion gap. If you have metabolic acidosis with anion gap of more than 12, we will call it as high anion gap metabolic acidosis. Generally, high anion gap metabolic acidosis occurs when an extraneous or an extra acid gets added to the body. For example, if you have diabetic ketoacidosis, a typical example for high anion gap metabolic acidosis, keto acids are generated or extra keto acids are added to the body. And that extra keto acids they account for this anion gap that we are seeing, because we are not measuring them. They are anions, keto acids. We are not measuring them, so they are accounting for this gap that we are seeing. Or it could be methanol poisoning, where methanol is added to the body, but we are not measuring it in the equation, so we are creating a gap. So let's do that exercise as well. So we had one question on metabolic acidosis. So let me add the extra information that we need. So this patient's serum sodium is, let us say, is 140 millimoles per liter or milliequivalents per liter, and this person's chloride value, let us say it is 100 millimoles per liter. So can we calculate the anion gap in that case? So anion gap now is sodium, which is 140 minus sodium is a positive ion, and the negative ions here are chloride and bicarbonate. So chloride is 10 and bicarbonate is 10 and chloride is 100. 100 chloride plus bicarbonate 10. So that becomes 140 minus 110. So gap here is 30. So that means this patient has a partially compensated metabolic acidosis, which can be labeled as high anion gap metabolic acidosis. So this is a partially compensated hagma. So in this patient, this anion gap is because of an extraneous acid being added. So same question, I might give you the context. I might say that this is a known case of diabetes presented with a blood glucose level of 400 plus, right? And patient's urine ketones are positive. So what's the diagnosis? So you have diabetic ketoacidosis leading to high anion gap metabolic acidosis, which is partially compensated by the respiratory system. And this is what you call as acidotic breathing or Kussmaul's breathing, because now this patient has developed the metabolic acidosis. So respiratory system is forced to expel a lot of carbon dioxide because we have to lower the blood carbon dioxide level. So patients start developing hyperventilation to wash out the carbon dioxide, and you call it as Kussmaul's breathing or acidotic breathing, which you can see in patients with diabetic ketoacidosis. So that's it from me today. So similar questions you can expect. So keep this flowchart in mind. Approach 3-4 ABG based questions and you will get the clarity on how to approach, or if you are stuck, you can definitely ping me on the Instagram and I'll help you out with some more problems. I will ask the team to give me another one session where we will have another 20-30 important questions, mainly coming from, we have not touched the depth of rheumatology, we have not touched the depth of neuro. So we'll concentrate on neuro, rheumat, and to some extent some important topics from GIT as well in another session. So till then, have a good time guys and study well. Okay, so thank you all guys. See you soon. Till then, have a good time. Bye-bye.